Καλημέρα σε όλους, τους ζωντανά παρόντες και τους ανθρώπους που έχουν συνδεθεί στο διαδίκτυο. Ακούω ότι έχουμε 70 συμμετοχές από το διαδίκτυο. Αυτή η ημερίδα είναι συνέχεια μιας άλλης που ξεκίνησε που έγινε πριν από 4-5 χρόνια, που αφορούσε μια πρώτη προσέγγιση για το πώς μπορούμε να βελτιώσουμε τις συνθήκες παροχής υπηρεσιών τραύματος στη χώρα. Από τότε έχει τρέξει πολύ νερό, νόμοι, υποτροφίες, υποστήριξη από μεγάλους φιλανθρωπικούς οργανισμούς έχουν αλλάξει τα δεδομένα στο τραύμα. Αλλά όπως πάντα, κάθε πρόοδος φέρνει καινούριες προκλήσεις. Δεν είναι αρκετά όλα αυτά, πρέπει να πάμε παρακάτω. Επομένως, αυτή η συνάντηση είναι συζήτηση για το πού θα πάμε παρακάτω, πού πρέπει να πάμε και πώς θα φτάσουμε εκεί. Έχουμε εκλεκτούς καλεσμένους που θα χαιρετήσουν στην αρχή και θα τους παρουσιάσουμε έναν έναν. Πρώτος, ο κύριος Αρκαδόπουλος, Dean of the Medical School of Athens. So we'll speak in slightly in English because we have the ambassador of South Africa with us. So please, Professor Arkadopoulos, please come and say welcome.
Καλημέρα σας. Your Excellency, Ambassador of the Republic of South Africa, Professor Msengana Ndela, esteemed colleagues from Greece, from all over the world, Mr. Professor Chrysofos, the Head of Surgical Services of Αττικόν Hospital. For me, it's a great honor to be with you this morning and to address this meeting on behalf of our rector of the University, National Kapodistria University of Athens, Professor Skiasos, and on behalf of the administration of the medical school. So, welcome all to Αττικόν University Hospital. Welcome to our medical school. And please allow me to start by expressing my deepest thanks and congratulations to the two organizers of this meeting, Professor Vasiliou and Professor Koulouvaris, who put together this excellent meeting and also have a long contribution to the organization and development of a trauma system in Greece, and we are very grateful to them for that. I would also like to express our gratitude to the Republic of South Africa and the colleagues who are here present with us for their contribution to the education of Greek physicians in trauma. Trauma is a really very complex endeavor and one of the most complex in medicine, and the South African system is very well organized, very well known for that, and we are honored to have this collaboration. And as you know, there have been many Greek physicians who trained in South Africa, and I just happen to remember the name of three of the most famous of them. Professor Dimitris Dimitriadis, who was in South Africa and later became the head of trauma at USC LA County Hospital in the United States. Of course, Professor George Velmachos, who also trained in South Africa, and he is currently the head of trauma and emergency surgical care at Harvard. And Professor Ilias Degiannis, who I'm sure you all know, who also was for many years in South Africa. So we have, beside the historical ties between the two countries, we also have this very strong educational collaboration. We have recently signed an agreement with the University of Witwatersrand and many hospitals, and it's a very active collaboration, and we are very grateful for that. Our university, our medical school, being the oldest and most prestigious, highest ranking medical school, not just in Greece, but also in Cyprus and in the whole area of Southeastern Europe, has dedicated a lot of effort in the education in trauma medicine and trauma management, trauma surgery. A few years ago, we started the only in Greece postgraduate program at a master's level for trauma education, and Professor Vasiliou, who is here, is coordinating this program. We also started clinical fellowships and a lot of activities, congresses, conferences, hands-on education, most of them headed by Professor Vasiliou and Professor Koulouvaris. So we're trying our best as a medical school to contribute to this national effort, which has been going on for the last years for the development of a trauma system in Greece. I'm sure that with the contribution of our experts from South Africa, we will move forward. And thank you again for your presence here. And finally, I would like to mention that today is International Women's Day, and the presence of women in the academic surgery in Greece is getting stronger and stronger. We're very happy for that, and I would like to wish them all that they have a great Women's Day. A day filled with joy and appreciation for their offer and empowerment. So thank you very much for the opportunity to address this meeting today, and I'm sure it's going to be very successful. Thank you.
Professor Arkadopoulos put you in the idea why the ambassador of South Africa. We have with us for 1 week 4 exceptional surgeons from South Africa which teach hands-on practices in surgery, orthopedic surgery, our Greek associates. And this is not the first time. It happens since 2004. And they are with us constantly. These programs are ranking top among European programs because we are the only that bring that kind of expertise in our country to teach. All the rest randomly bring this kind of experience to their countries. So we are privileged to have this association and these friends from this country. So after all this, but before that, yes, it's the Day of the Woman today. At the end of this conference, we'll contribute to a very, very good surgeon from South Africa that is not with us anymore, a woman. You will see what she has accomplished during the brief period of her life. And after that, this is a contribution for the Day of the Woman. After that, every woman in the audience will take a flower as a gift, a rose as a gift. And after all this, please, I invite the ambassador of South Africa to salute us, Dr. Lindwie Msengana Glela.
Program Director, the Honorable Deputy Minister of Health in the Hellenic Republic, Mr. Themistokleous online, the Dean of the Medical School of Athens, Professor Akathopoulos, Professor Michael Lis Chrysophos, the President of the Scientific Committee and Surgical Section, the President of the Hellenic Surgery Society, Professor Pikolis, Professor Vasiliou, and Panagiotis, President of the Organizing Committee, medical professionals and scholars that are here, distinguished guests and associates from South Africa, professors and doctors Rian Pretorius, Tamsan Ngamazibuko, Chido Nyansambo, and from Namibia, Dr. Shaban Kai. Ladies and gentlemen, it is a great honor to be with you today and represent the Republic of South Africa at this trauma conference that is held at the Attikon University General Hospital. I would like to heartily congratulate the co-organizers for their efforts in bringing together experts that are dedicated to advancing trauma care and improving patient outcomes. I also wish to extend a special word of gratitude to our surgeons who have traveled all the way from South Africa and Namibia. Not the first time, and they have traveled to participate in this conference and will be the lead instructors in training courses. Some have started already this week, and they will participate in courses that are continuing from tomorrow. Our presence here today reflects the solid relations that we have between the Hellenic Republic and South Africa. Our presence demonstrates our support for the public health systems of both countries and the excellence of our academic hospitals. We also appreciate good relations between the Hellenic Republic and countries in the Southern African Development Community, also known as SADC, including Namibia and the African continent at large. Ladies and gentlemen, most of you will be aware that South Africa is celebrated for advances and innovations in surgical care. I would like to mention a few of these landmark innovations. The first heart transplant by Dr. Chris Barnard at Groote Hospital in Cape Town. The first 3D implant to cure deafness by Dr. Mashudu Shifularo at the Steve Biko Academic Hospital in Pretoria. The recent establishment of programs which provide access to minimally invasive surgery through laparoscopy and robotic surgery in public hospitals, such as Groote Hospital and Tygerberg Hospital in Cape Town, and the establishment of South Africa's first robotic-assisted surgery training center at the University of Pretoria. Furthermore, South Africa has a wide range of surgical services available across all the different levels of care, including trauma care. We have established trauma systems with dedicated trauma units and centers across the country. This is particularly the case in high-volume areas, since we are a country with a population of approximately 63 million people and 9 provinces. The 63 million people is from Statistics South Africa last year, 2025, and the number is growing. The Chris Hani Baragwanath Hospital, where Professor Pretorius, Dr. Mazibuko, and Dr. Nyanzambo are based, is in the highly populated Black Township of Soweto in Johannesburg. In preparing to meet with you today, I came across, because I had to read, colleagues, I had to read very hard. I came across an interesting 2025 research paper published in the Journal for Surgical Research based on a study that was undertaken by researchers from various academic hospitals and universities. And these researchers included Rian Pretorius, who is with us today. And the paper is about trauma electives in South Africa and how they provide invaluable experience to international doctors, particularly in the case of Johannesburg. There are at least two matters of evidence and insights that stood out for me as I was reading the paper. Firstly, that Chris Hani Baragwanath Academic Hospital in Johannesburg is the largest trauma center in South Africa. It is a referral center for much of the Gauteng province, which has 11.4 million people. These numbers tell us why South Africa is one of the most sought-after destinations for trauma electives among international medical trainees. It is noteworthy from this study that 84% of those who completed their electives during the period under review at the South African trauma centers originated from Europe. This is a big number, 84%. Furthermore, the paper demonstrates that South Africa's trauma surgeons are contributing immensely to pioneering work in the fields of trauma care and trauma surgery. They are collaborating with colleagues within the African continent, with Europe, and globally in the development of strategies, policies, technologies, and practices that seek to improve trauma care. Secondly, from this paper, we are reminded that trauma care has changed dramatically over the last 3 decades. In recent years, it has been driven by geopolitical instability, global terrorism, dramatic increases in urban violent crime. I dare add to this list the scourge of gender-based violence in our societies, the scourge of GBV. This observation is most relevant today on the 8th of March 2026 as we recognize the United Nations International Women's Day. This year's theme is rights, justice, action for all women and girls. We all know that disparities in healthcare affect women and girls the most throughout the world. We hope that participants in this medical field will intensify efforts to remove barriers that prevent women from receiving timely and quality surgical and trauma services. Regarding skills development programs, the Colleges of Medicine South Africa, known as the CMSA, is a premier institution which stands out globally due to its 29 constituent colleges. It contributes to specialized training for surgical, trauma, and emergency medicine care, not only in South Africa, but also in the rest of sub-Saharan Africa. There is also a growing focus by some academic institutions on surgical service delivery and training that is directed at strengthening surgical systems in the public sector. One example is the University of Cape Town, which offers a master's degree in public health with specialization in global surgery. Of course, there are challenges, and we must talk about them. Despite the advances in access to surgical care, there are still alarming disparities in access to this care globally. But in the case of South Africa's of South Africa, these disparities have their roots from the legacy of apartheid's institutionalized system of discrimination, racialized underdevelopment, and high levels of inequality. Since the dawn of the new democracy that was led by President Nelson Mandela in 1994, to our current president, His Excellency Cyril Ramaphosa, there are redistributive policies that are progressively being implemented with partnerships that are led by our Department of Health in order to advance the goal for universal access to health. These advances have also been registered in this field of surgical and trauma care. Like most countries and in varied forms, there are limited budgets and resource constraints. However, despite these constraints, South African public health systems and facilities are achieving remarkable results using models that challenge traditional platforms, such as the limited roles of district facilities. Instead, our government and stakeholders in the health system have effectively designated district-level emergency centers that can be used appropriately for complex trauma management. These successes also reflect the importance of dedicated teaching, structured training, effective supervision, and timely referral systems. A functional ecosystem of care is available even in under-resourced environments, enabling the performance of complex procedures safely and effectively, and thanks to professionals that are here today. You will hear from them, not me. Lastly, the most recent priority in trauma care is prevention. Nearly half of trauma deaths could be prevented with improved health systems. South Africa is continually investing in medical education, outreach, and mentorship. The development of locally based trauma courses is equipping providers with context-specific skills, because context matters. And in my presentation to you today, I'm talking about the context in which the doctors come from, who are here today with you from Africa. To the Deputy Minister online, we hope that the participation of trauma surgeons from our country will strengthen the bonds between South Africa and the Hellenic Republic. Knowledge sharing is crucial as we all seek to build equitable health systems and a skilled workforce that can respond effectively to today's challenges of complex trauma. In conclusion, I'd like to thank the conference co-organizers for setting aside time in today's program for a special tribute to a distinguished and remarkable South African, the late Dr. Vicky Jennings, who passed on in 2024. She was the deputy head of trauma at the Chris Hani Baragwanath Academic Hospital. Young, made an impressive contribution to medicine. And when I see young scholars here, I'm encouraged because I see the future. And I think Dr. Jennings would have loved to be here to see you. And thank you for setting aside time today to honor her. I wish you all a successful conference and fruitful deliberations. Thank you so much, Evaristo Poli. Thank you.
The next speaker that we salute is Professor Michalis Chrysofos, the head of the surgical section and the scientific committee of Αττικόν Hospital, representing our hospital.
Esteemed Ambassador, Professor Linda Mesgana-Della, esteemed Decan of Medical School, distinguished guests, dear colleagues, it's my great pleasure to welcome you to today's symposium dedicated to trauma, a field of medicine that requires prompt response, a high level of scientific expertise, a close collaboration among multiple medical specialties. Continuous education and the exchange of experience among healthcare professionals are essential for improving the care of trauma patients. I'm confident that today's presentations will contribute meaningfully toward this goal. As a president of the scientific committee, I would like to congratulate the organizer and especially Professor Adelis Vasiliou and Professor Koulouvaris, and sincerely thank the speakers for their valuable participation. I wish you all a productive and engaging scientific meeting. Thank you.
Ευχαριστούμε τον κύριο Χρυσοφό. Manuel Spikulis, the next speaker, will come later on because he has another obligation. And now we go to the salutation of Deputy Minister of Health, Dr. Marios Themistokleous, who sent a brief message with a video.
Καλημέρα σε όλους. Καταρχήν επιτρέψτε μου να απολογηθώ γιατί οι ανηλυμένες υποχρεώσεις δεν μου έχουν επιτρέψει να βρίσκομαι σήμερα εκεί μαζί σας στο Αττικό νοσοκομείο για να παρακολουθήσω την εξαιρετική αυτή ημερίδα. Όπως γνωρίζετε, στη χώρα μας έχει γίνει προσπάθεια τα τελευταία χρόνια έτσι ώστε να βελτιωθούν, να γίνει καλύτερη η αντιμετώπιση του τραύματος και στη δική μας χώρα. Όπως όλοι γνωρίζετε, το τραύμα αποτελεί μια από τις βασικές αιταιρείες θανάτων, ειδικά στις πιο νεαρές ηλικίες, αλλά και βαριάς αναπηρίας. Στη χώρα μας έχει γίνει μια πολύ μεγάλη προσπάθεια, συντεταγμένη τα τελευταία χρόνια, κάτω από τις οδηγίες ειδικών στο τραύμα και έτσι ώστε έχουμε καταφέρει αυτή τη στιγμή να έχουμε προδιαγραφές για τα τμήματα επιγόντων των περιστατικών, προδιαγραφές οι οποίες έχουμε καταφέρει να ενσωματώσει στις ανακαινήσεις που γίνονται με τα έργα του Ταμείου Ανάκαμψης Κατεκτικότητας και έτσι αυτή τη στιγμή έχουμε τμήματα επιγόντων περιστατικών στα νοσοκομεία οι οποίες πληρούν τις προδιαγραφές που είναι σύγχρονες, οι οποίες είναι αυτές που ζητήθηκαν από τους επιστήμονες και τους υγειονομικούς που ασχολούνται με την αντιμετώπιση του τραύματος. Σε αυτή την προσπάθεια είχαμε τη ψήφιση του νομοσχεδίου για την δημιουργία των κέντρων τραύματος. Έχουμε κάνει αρκετά βήματα προς αυτή την κατεύθυνση, σίγουρα όμως χρειάζεται να γίνουν και περισσότερα. Θα ήθελα να αναφερθώ εδώ επίσης στο σχεδιασμό της δημιουργίας του Registry του τραύματος. Αυτή τη στιγμή στη χώρα μας έχουμε ενεργοποιήσει τον ψηφιακό φάκελο ασθενούς, άρα έχουμε μια σχετική ευκολία αν καθοριστούν τα πεδία τα οποία θα πρέπει να υπάρχουν, να μπορούν να αποκτήσει και η χώρα μας ένα πολύ καλό αρχείο μητρό όσον αφορά το τραύμα, το λεγόμενο Registry. Και θα ήθελα να κλείσω αναφερόμενος στις αεροδιακομιδές, οι αεροδιακομιδές και στις πρωτογενείς και δευτερογενείς αεροδιακομιδές. Οι δευτερογενείς αεροδιακομιδές αυξάνονται με πολύ σημαντικό ρυθμό τα τελευταία χρόνια. Προσθέτουμε εμείς και επιπλέον πτυτικά μέσα. Να σημειώσω εδώ την δωρεάν του τρίτου αεροσκάφους από το Ίδρυμα Σταύρος Νιάρχος, πέρα από τα 2 ελικόπτερα, 2 αεροπλάνα τα οποία είχε δωρήσει στο παρελθόν. Προσθέθηκε ένα τρίτο αεροπλάνο. Το περσινό καλοκαίρι προσθέσαμε και εμείς ένα άλλο ελικόπτερο στην Πάρο καθώς και στην Ρόδο για τους καλοκαιρινούς μήνες. Και αυτό που χρειάζεται η χώρα μας είναι να φτάσουμε σε ένα πλήρως οργανωμένο σχέδιο αεροδιακομιδών, πρωτογενών και δευτερογενών αεροδιακομιδών. Κλείνοντας, θα ήθελα να αναφερθώ σε δύο πολύ σημαντικούς γιατρούς. Όπως έχω ήδη πει, στην προσπάθεια για να γίνουμε καλύτεροι στην αντιμετώπιση του τραύματος στην χώρα μας έχουν συμβάλει οι επιστήμονες. Οι επιστήμονες που κάτω από την δική τους καθοδήγηση, τη δική τους συμβουλευτική, έχουμε πετύχει τα σημερινά αποτελέσματα. Τα δύο όμως πρόσωπα αυτά, ο καθηγητής ο κύριος Παναγιώτης Κουλουβάρης και ο καθηγητής ο κύριος Βασιλείου Παντελής, είναι αυτοί που πέρα από την επιστημονική τους γνώση, ορισμένες φορές η επιμονή τους, η μεθοδικότητα, αλλά κυρίως η επιμονή τους, είναι αυτή που έχει φέρει τα αποτελέσματα. Ο κύριος Παναγιώτης Κουλουβάρης, με την διδασκαλία στην αντιμετώπιση του τραύματος, είτε το ATLS, είτε το πρόγραμμα για τους νοσηλευτές, το πρόγραμμα για τους διασώστες, ήταν αυτός που οργάνωσε, έπεισε το Ίδρυμα Σταύρος Νιάρχος και αυτή τη στιγμή συνεχίζουμε το πρόγραμμα και η συμβολή του είναι εξαιρετικά σημαντική στην αντιμετώπιση του τραύματος στη χώρα μας, γιατί αν δεν έχεις εκπαιδευμένους επιστήμονες, δεν μπορείς να έχεις και καλή αντιμετώπιση. Και ο καθηγητής ο κύριος Βασιλείου Παντελής. Ο καθηγητής ο κύριος Βασιλείου Παντελής, που αποτελεί την ψυχή που και αυτός με τη δική του επιμονή έχουμε καταφέρει το σύνολο, η ομάδα, να έχουμε φέρει συγκεκριμένα αποτελέσματα. Και στο επίπεδο των προδιαγραφών στα τμήματα επιγόντων των περιστατικών, αλλά και σε διάφορους άλλους τομείς στην αντιμετώπιση του τραύματος, ο κ. Βασιλείου Παντελής, που έχει σκοπό τη ζωή του στη βελτίωση των συνθήκων, είναι αυτοί οι οποίοι οδηγούν αυτή τη στιγμή την βελτίωση των συνθήκων στην αντιμετώπιση του τραύματος στη χώρα μας. Με αυτά τα λόγια, να συγχαρώ για την εξαιρετική διοργάνωση της σημερινής ημερίδας και να ευχηθώ καλή συνέχεια στις προσπάθειές μας για την βελτίωση των συνθηκών αντιμετώπισης του τραύματος στην χώρα μας. Καλή σας μέρα. Καλημέρα σε όλους.
Ευχαριστούμε τον Υφυπουργό για το μήνυμα που έστειλε. And now we move on to the scientific session. The first 2 hours, the 4 South African guests will speak about interesting things for our Greek associates. And the second session will be plans for the future. So I call Panagiotis Koulouvaris to come on the podium. And we start with Sidonia Sambo from Chris Hani Baragwanath Hospital, and this is accurate, the biggest hospital of trauma in the world, 80 admissions per weekend of severe wounded people. This compared to the United States is 5 per weekend. This, as you realize, is 40 times more. Huge experience. They can train hands-on people that want to do this, and they need them. And also, in this way, they convey their expertise. So, Chido, please.
Okay, great. Good morning, everybody. Thank you so much for having us. And today I'm going to be discussing something that's rare in our setting, but we see quite a bit of it. I'll be discussing subclavian vessel injuries. So this includes the artery and the vein. And there's going to be some participation. So everybody must get their phones ready. And when you see the QR code, you can just participate and answer some of the questions. It just helps to gauge how much everybody has seen, what you guys know, and then we can have a better and a more in-depth discussion about it. So the first question I have to ask is, how many people have experienced or have seen injuries to the subclavian vessels? You can say yes if you know for sure, no if you haven't, and then if you're not sure, you can also write not sure, because some of us aren't sure what we've seen or what we haven't seen. Okay, so we've got about 13 people who've replied, and actually majority of people haven't seen these injuries, which is quite interesting. But it just speaks to the fact that if you haven't seen it, you're not aware of the injury, and so your exposure and identifying your injuries becomes a little bit difficult because you don't really think about it and you don't have a high index of suspicion. All right, so we're going to be talking about how to recognize the injury early. So looking at the different mechanisms, because in trauma we always talk about a blunt mechanism or a penetrating mechanism. We're going to talk about some of the signs and symptoms, the most obvious things that you have to look for when you identify these patients. We're going to be deciding between how to work up the patients. Do you have time to work up the patient? Or is the patient too unstable from a bleeding point of view and a physiology point of view, and you actually have to intervene emergently? And then, depending on what your patient is doing and how they are, how can we intervene? Do we have to do open surgery? Can we employ endovascular techniques? Or can we do combined techniques? Because each approach has its own complications and morbidities associated with it. So the subclavian region is a difficult region. It's at the basically the beginning of the chest, the thoracic inlet, and we've got our sternum there, we've got our clavicles, we've got our first ribs, and our subclavians basically go from the aortic arch, they curve around, and they're in between the clavicle and the first rib, and they're also sheltered by some muscles. There's a lot going on in that area. You've got a subclavian vein, you've got the apex of the lung, you've got the thoracic duct, and you also have the brachial plexus, which is really important for the functioning of our arms. So the anatomy already is complex, all right? So if the anatomy is complex in the normal person, you can imagine once the patient is injured, how much more difficult it becomes with regards to actually navigating, managing, and making sure your patient comes out in the same way, if not better off after their injury. So I like this picture. This picture I took from one of the articles. It's actually the biggest series from Brazil on subclavian injuries, okay? So subclavian injuries are very rare. It's more common in your areas where you've got lots of penetrating trauma, because that's the most common mechanism. It's not really well associated with blunt trauma, but we'll go into that. And this picture just depicts the difficulty with regards to the anatomy, because the aortic arch in the books, it's 2D, so it looks like it's going to the left, right? But actually, in real life, it's going to the back. And so getting access to these injuries and these vessels can be quite challenging. For myself, it's different for different surgeons. I always say the left is more challenging than the right. But I mean, for example, if you get a patient who's got a gunshot, who's bleeding actively, whether it's the right or the left, it's going to be challenging. So you have to have a good idea of the anatomy and what you're going to do for these patients. So like I said, it's a rare injury. You got to think about the mechanism. Is it blunt? Blunt, you have to have a high index of suspicion of it because it doesn't present in the obvious way after penetrating injury. Penetrating, they're going to bleed. Blunt, you've got lots of force that's going through the area. So when your patient comes with a clavicle fracture, a first rib fracture, sternoclavicular joint disruption, or some patients have actual disruption of this whole complex of the acromioclavicular, the glenohumeral joint, the scapula, the sternum. That's when you think about the injury. And essentially, it's a traction kind of injury. So you get a tear of the intima. Depending on how bad the injury is, you can get a pseudoaneurysm or you can get a complete transection of the artery. So these patients, usually maybe they can come unstable and they respond to resuscitation, but you're going to be imaging the patient. But patients who've got an excessive blunt force to the chest area, to the clavicles, to the sternum, you got to think about major vascular injuries, including the aorta. Penetrating in our setting is way more common than blunt trauma. So we divide it into low velocity and high velocity. Your low velocity would be your stab wounds. Your high velocity would be your gunshots, okay? Depending on which part of the world you are, you can either get shot with a low velocity gun or you can get shot with a high velocity gun. So we see a lot more low velocity guns compared to your rifles, etc. And again, sometimes the diagnosis isn't so obvious. And so when you're dealing with these kind of patients, I always like to say, you got to have a high index of suspicion and you got to keep the injury at the back of your mind all the time. So the most obvious ways to look for signs and symptoms would be your hard signs and your soft signs. So you've got hard vascular signs, soft vascular signs. Your hard vascular signs always tell you that there's most likely an injury. So you're not going to have a pulse. You're going to have signs of ischemia, which means that the limb isn't being perfused. You may have an audible bruit. You may have a thrill. The patient may actually come exsanguinating, so they're bleeding to death, and you can see that it's arterial blood. And you may have a hematoma that's pulsatile or that's continued to expand. That kind of patient is an urgent patient, and those kind of patients you would take them straight to theatre and do an exploration, as opposed to doing imaging and doing like a CT scan and then identifying the injury and then deciding how you're going to manage that injury. So these kind of patients are basically patients who are bleeding and they are compromised and they need you to do something about them. So I always like to think to myself when I'm dealing with patients, where's my patient falling? Are they a responder? So does that mean that they're responding to resuscitation? Whether it's with fluids and blood products, and I've got time to work up the patient, or are they a transient responder, which means that they come in initially unstable, and I can resuscitate the patient, and then they go back to being unstable, which means that I don't really have that much time to image the patient. But if it's extremely complex, for example, if it's a multiple gunshot who's been shot in the chest, in the abdomen, in the lower limbs, and I'm wondering where they're bleeding from, can I resuscitate them enough to be able to, for example, scan them so I can see what the trajectory of the bullets are? Or is it a non-responder, as in a patient who comes in unstable, they're bleeding, and we don't have time to image them, therefore I must rush them to theatre to explore them? It helps you to decide what you can and cannot do for the patient. And it's really important with subclavian injuries, because your patients either come, and I've got 2 case presentations to show you about the different way that the patients present. And the different kind of thinking you have to be able to figure out how you're going to fix the patient. So there's different management options as well, depending on the right or the left, depending on whether you're going to do open surgery or you're going to do endovascular surgery, depending on whether or not you can use a combined approach. So, for example, the idea with vascular surgeries, you got to get proximal control and distal control so that they're not bleeding, and then you go for the injury, you identify the injury, and then you repair it accordingly. So you can either go through the chest, do a median stenotomy, and that shows you the arch of the aorta well, and you can get proximal control easily at the origin of the vessel. If the injury is more distal from the origin of the vessel, you may think of doing an infraclavicular incision or a supraclavicular incision. So, I hope I'm demonstrating the complexity of the decision-making when it comes to these injuries. There's a lot going on, all right? And then if your patient is sort of stable, as in they respond to blood products, and you also have an endovascular suite, you could think about getting control endovascularly and then dealing with the injury with a surgical approach. So, yeah, it's quite interesting. So our first case is a 20-year-old male. It was a Saturday night, it was really busy, and he presented at 3 a.m. after sustaining a stab to the neck, right, in zone 1, as well as a stab to the chest on the left infraclavicular. So he was referred to us from the local clinic, and they were suspecting that he had a right hemothorax because he had a left hemothorax because he had decreased air entry. But they didn't have intercostal drains, so we told them to send the patient to us. And when he arrived, he was hemodynamically unstable. So his blood pressure was about 90/60. He was going at a heart rate of 140. Unfortunately, at the time that he arrived, I was in theatre with another gunshot, abdomen, and I was operating on that patient. So this is what the stab to the neck looks like, okay? So it was probably about 1 centimeter above the clavicle. All right, and so I told them quickly get a chest X-ray and let's see but let me ask you. So if you get this patient, he's unstable, you're in theatre with a gunshot, okay? So you've got another junior colleague who's in casualty. What would you advise them to do? So the blood pressure is 90/60, and he's got decreased air entry on the left side, and he's got a heart rate of 140. His GCS is 13, and that's the stab. So would you resuscitate according to ATLS principles? So you put up lines, you give him blood and blood products, and then you're going to call for help. Would you do a chest x-ray, ask for a chest x-ray? Would you tell them, I'm operating quickly, send the patient to CT scan so we can see what's going on? Would you tell them to call the vascular surgeon? Or would you decide to get another junior to come and finish your operation, go and resuscitate this patient, and then take him to theatre? These are all viable options except I wouldn't send the patient to CT scan though because he's unstable. So that, for me, that one would not be a viable option. Okay, so most people are saying resuscitate according to ATLS and then call for help, which is a good option. Some would call the vascular surgeon, great. Depending on where your vascular surgeon stays, they could be 30 minutes away, they could be 45 minutes away. People would resuscitate and take the patient to theatre, cool. So I told them, resuscitate the patient, put up lines, get blood and blood products, and do a chest x-ray for me. So they did a chest x-ray, and as you can see, we had a hemothorax, and we also had a pneumothorax. So I asked them to put an IC drain in, and that's what the chest looked like after we put an IC drain in. I was still in theatre dealing with this gunshot. It was a bit complex. And probably about 30 minutes after this, they came to tell me that he had bled 2 liters. So I told them to auto-transfuse the patient. So give him back the 2 liters of blood and transfuse him. And we're going to book him for theatre as soon as we're done with this patient. The patient then bled another 2 liters while I was finishing up. Then they came and told me, and then I told them, okay, fine. We managed to open another theatre, get him into theatre, and we took him to theatre. So what kind of incision would you do for this patient? So like I said, it was probably 1 centimeter just above the clavicle, just above the sternoclavicular joint, all right? I didn't have a CT scan to see which part of the subclavian the injury is at, okay? And the patient is unstable. So would you do a sternotomy? Would you do a supraclavicular incision, an infraclavicular incision, call for help? Okay, so a lot of people are doing sternotomy for proximal control. That's a fair option. People are calling for help. I was also thinking of calling for help at that point. So it's important to know that you might have to do combined incisions, right? You can do a sternotomy for proximal control, but what are you going to do for distal control? Where are you going to get control of the axillary or the part 3 of the subclavian? Because you'll get back bleeding, all right? So both left and right, if you've got an injury on the part 1 of the subclavian, you're going to do a sternotomy for proximal control. Then you have to ask yourself, where is my injury? You know, is it in part 2 or part 3? Okay, and sometimes the other day we were doing another subclavian, and it was a proximal injury. We started with the sternotomy, and then the patient started bleeding, and we couldn't go supraclavicular, so we had to get distal control in the axillary, and then we had to come back to the supraclavicular to find the injury. So you got to think about how you're going to use the incisions, and sometimes you've got many incisions, and sometimes your boss will come in the morning and say, why do you have so many incisions? And then you just got to tell them, at least the patient is alive. Okay, so right side, you're going to do proximal control with the median sternotomy. Sometimes you can get it supraclavicular because of where the right side branches off, and usually you always have infraclavicular. On the left side, it becomes a little bit more difficult, but usually for proximal control, always median sternotomy, and then a combination of your supraclav and your infraclavicular incision. The beauty about the first world is that a lot of people have hybrid theatres now, and what you can actually do is you can have 2 teams. One team gains access of the femoral artery, all right, and they deploy a balloon proximally, endovascularly, and then you can go and get distal control, and you can then identify the injury and fix it. Unfortunately, we don't have a hybrid theatre, so we don't have the luxury of using that technique. And sometimes also, if your patient is stable, they're responding to resus, you can try to do a whole endovascular approach and put a stent graft over that injury, depending on whether you got a pseudoaneurysm, or just like a small, a partial transection with some extravasation, depending on what your angio finds. And then this is not very common, but sometimes you can get an intimal flap or you can get a low-grade injury, and you can actually manage these patients conservatively. So that's the sternotomy, okay? So we started with the sternotomy, and we got proximal control with the sternotomy, and then we came and we actually did a infraclavicular incision, all right? And we managed to get the injury. It was a part 3 injury, and that's the injury there. So we had a partial, about 50% transection of the subclavian vessel. At this point, the patient was like unstable, but not really unstable because they were resuscitating with blood and blood products, but the patient was on inotropes. So because it's in part 3, my next question would be, and this is the grading, my next question would be, how would you actually repair it? We'll go back to the grading. Would you do a primary repair, as in just suture it? Would you do a resection and a primary anastomosis? Would you do an interposition graft, which means that you resect the area and then you put a graft in between? Or because the patient is a bit unstable on blood and blood products on 0.5 mics of adrenaline, would you ligate the patient so you can go to ICU and be resuscitated for longer? Okay, so there's a lot of people who are doing an interposition graft. But remember, with an interposition graft, you're going to add another 15 to 20 minutes to go and find the reverse saphenous vein, okay? Your patient is unstable, right? They're on inotropes, they're getting blood and blood products. So it's not fully transected. So in this, here we decided to actually do a primary repair, okay? Because our patient is unstable, it's a stab, and so there wasn't actually progression of the intimal injury along the vessel, all right, which means that if we do a primary repair, it's unlikely to thrombose, and we didn't have to debride or resect, which means that we also didn't cause any stenosis of the vessel. So we did a primary repair. Resection, primary anastomosis, if you don't have if you have to resect the injury because it's quite a bad injury or there's associated intimal damage, can you safely bring back that vessel together without causing tension and without causing stenosis? That's something that you have to think about. And then, like I say, with an interposition graft, in the patient who's hemodynamically unstable, do you have time to then also go now do a saphenous vein harvest, all right, and then come back and do your graft, because that'll add time to your procedure. And if they're severely unstable, I didn't give you guys this option, you could shunt it, all right? Or depending on where the injury is, you can actually ligate the injury. Okay, so in our setting, we've had to use ligation sometimes, and the one time I was involved in ligation was a patient came 3 days post his injury. Vascular, didn't have stents to stent him. We took him to theatre. The thing about these patients is that they can become extremely unstable very quickly. And he became extremely unstable very quickly, and we decided to ligate it because we were about to lose the patient's life. So there's a lot of options that you can do, but you have to think about the best. How it fits with your injury. Okay, we'll go back to grading. How it fits with the injury, all right? And how you can actually, at the end of the day, you want to save the patient's life, all right? So life over limb. So can you ligate it and come back and fight another day? And then shunting, people always say shunt, 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 but not everybody actually knows how to shunt. So that's one of the things. And how far is help? Is help 45 minutes away? Is help 5 minutes away? Okay, that's very important. So whenever you operate, you're obviously going to identify the injury pattern, all right? Is it an intimal flap or a mural thrombus, which you identify in CT scan, which you may be able to manage conservatively? Is it a pseudoaneurysm? Okay, usually pseudoaneurysms you may have to intervene surgically, but if you have the ability or the stents and the resources, you may be able to do it endovascularly. Is it a free rupture? Free rupture is usually associated with active extravasation or exsanguination, all right? So you're going to sort that out. Or is the vessel occluded? Okay, you may then have to actually sort it out. And do you have an AV fistula? Is it a high-grade AV fistula or a low-grade AV fistula? Low-grade AV fistula, you may get away with doing something, or you can do something endovascular both, but if your patient is unstable, is in heart failure, you don't have quick access to endovascular, you may have to take your patient to theatre and sort out that AV fistula. The other complexity about these injuries is that the subclavian vein is very close to the subclavian artery, and the venous injury is actually worse than the arterial injury, because the venous injury just bleeds continuously. And you'll be operating and the person who's suctioning just keeps on suctioning the blood and you're trying to find where the patient is bleeding from. And lo and behold, the anesthetist will tell you, you've got 4 liters of blood in the suction. Okay, so the venous injuries are very difficult. And whenever I'm operating, I always ask myself, the first question is, where's the vein? Is there a venous injury? Because it's what I must address first by ligating it. And then you'll obviously always have your combined injuries, your artery, your vein, your brachial plexus. It's important to note if you have a brachial plexus injury, tag it and get the plastics to recon it at the appropriate time. Cool. So we said primary repair. So that's what we did. We basically did a small debridement and we did a primary repair of the patient. And then we closed him, we left a small drain, and he did well post-op. So in summary, this patient was a stabbed neck and a chest. He was unstable. He had hard vascular signs because he didn't have a pulse. We made a decision to take him to theatre. We did a stenotomy for proximal control. Then we did our supraclav incision. And we had a partial transection, and we chose a primary repair that had a good outcome. Subsequently, some months later, we got referred another patient from a local clinic. It was a Sunday. The patient was stabbed on the Friday. He didn't go to hospital until the Sunday, all right, so he was a delayed presentation. And the only reason why he went to hospital was because he had this progressive area of swelling in his chest. So when he arrived, he was hemodynamically stable. He had diminished pulses on the left arm, but they were still present. His chest x-ray that we did was normal, and he had no other injuries. So we decided to scan the patient. Sorry, I just want to... Okay, so we decide to scan the patient. Can you all appreciate the hematoma that's coming up there? And you can see that contrast extravasation. There's the vessel. I'm going to go back. It's quite an impressive extravasation going in multiple directions. So that's very proximal. So he was stable, he's fine, he can use his arm, his GCS 15 out of 15. So that's what it looked like. That's okay. So that's the subclavian there, all right, coming through, and then that's the extravasation, and all of this is the hematoma. Okay, that's been expanding for the last 2 days while he's been at home. So in this instance, like I said to you, because these patients can come in walking and then they end up bleeding, we decided to call vascular. And vascular at that point was very helpful. So I just answered the question, would you do open surgery? Would you do endovascular? Is there anybody who would think of doing open surgery here? Because it is an option. Doesn't mean that you have to get endovascular. You can take this patient to theatre. And remember, it's not a pseudoaneurysm. He's extravasating. So it's not contained. So a lot of people have chosen endovascular. But like my question would be, especially for us, if it's over the weekend, are they going to do endovascular on the next available list, which means that he's going to go on Monday, Tuesday, or Wednesday, whatever day they have their list, or are they willing to do endovascular on the day? So our provisor for vascular that day was, you guys have to do it today, not on your next available list, because the patient was extravasating and he was having an expanding hematoma, right? So luckily our vasculars were quite keen that day, and that's what they saw on angio, which is quite impressive, right? I mean, that's an impressive extravasation. Yeah, it's like I said, it wasn't a contained pseudoaneurysm, and it was actually in part 1, okay? And they looked at the CT scan, and he had a dominant vertebral artery on the other side, and so they decided to stent it for us quite nicely. The fortunate thing about it is that we didn't actually have to take the patient back and then clear that hematoma. He actually did fine. He didn't have any compressive symptoms from that hematoma. So the thing about endovascular is that it's got advantages and disadvantages. Okay, the advantages are that you mitigate all the challenges and the morbidity and the risk of mortality from doing an open surgery. All right? In the short term, it has improved outcomes, and you're likely to have decreased surgical site infection. Okay? It's got good patency rates. All right? So primary patency was 42% at 5 years in some of the series. But what's important is that even if the stent ended up thrombosing, there were not many patients who actually needed to be re-intervened on. Okay, so they maintained functioning of their arm without developing claudication or signs of critical limb-threatening ischemia. So it's a good advantage to have. The disadvantages are that it is going to thrombose, and what happens in the patient that you actually develop symptoms and you're going to have to re-intervene. How are you going to re-intervene? Number 2, it's at a mobile area, okay? It's between the clavicle, the first rib, the shoulder joint. So the stent is at risk of fracture, all right? And number 3, how are you going to re-intervene when you do intervene? All right, and also these are patients who are going to need to be continuously followed up with vascular surgeons or the trauma vascular surgeon or the trauma surgeon. The problem with patients who usually sustain trauma is that they're patients who don't like following up. They don't come back to the hospital. They only come to the hospital when they're dying. Right? So it's not a patient who's going to come and you can do a CT scan every year and you can monitor this and they're going to take their aspirin and they're going to do that. So what does that mean for the patient? Okay? And then there's always patients who develop access site issues, okay? So there may be patients who get dissections, pseudoaneurysms, etc., and that has to be dealt with. So this was a stable patient. He came with a stab chest. He had a soft vascular sign, so we had time, so we opted to do imaging on him, and it showed extravasation of contrast at P1, P2 junction, and we managed to get him a formal angiography and do a stent placement. So I hope I've demonstrated how we recognize these injuries differently, okay? In the patients who you can't image, the patients who you have to take to theatre and you have to explore them. It's important to have an idea of the mechanism and the potential type of grade of injury that you're thinking about. It's important to be able to identify the different signs and symptoms because that also helps you to identify your strategy in managing the patients. You have to decide, that's the biggest thing, I think for me personally, is deciding between imaging versus immediate surgical exploration. The advantage of imaging is that it gives you a roadmap, okay? With surgical exploration, it becomes a little bit more difficult to identify and to think of where you're going to operate and how you're going to tackle the injury. And with these kind of patients, they get unstable, they are at risk, there's a really high mortality risk, and sometimes you can lose patients on table, all right, because it's complex and it's difficult. And then there's different management strategies, and number 1, it's life over limb, but number 2, you also want to do the best for the patient, okay? So is an open technique the best? Is an endovascular technique the best? And if you're spoiled, should you be doing a combined technique? Are there any questions?
If some of the audience, surgeons from the audience, want to learn more about these injuries, there is a course tomorrow and the day after that the associate from South Africa will teach in cadavers the dissection of the neck and the dissection of the subclavian area for trauma and many of those details will be elucidated, and above all, skill and knowledge of the area will be learned to an audience, the European audience, which is much less exposed to these areas than do in South Africa.
All right, let me just take you back to this anatomy picture. Okay, so the subclavian has 3 parts to it, all right? So you've got the origin of the subclavian, which goes to the medial aspect, well, it's okay, the anterior scalene and then beyond the anterior scalene. So the anterior scalene muscle, which is basically in the neck and it attaches to the clavicle, is what helps us to divide the subclavian. So the first part is from the origin to the medial part of the anterior scalene, okay? So that part is usually in the chest, okay? So you got to get proximal control in the chest, which is via median sternotomy. The second part is behind the anterior scalene muscle, all right, which is up here, okay? So you will do a supraclavicular incision, all right? You'll dissect, open the skin, subcutaneous tissue, you'll see some fat, you'll then identify the phrenic as it's crossing the scalene, you will then cut the scalene close to the clavicle, all right? And then you will look for your vessel, and it's usually peaking. It just comes there, like just behind the clavicle. On the right, it comes up higher. On the left, it doesn't come up so high. That's why the left is a bit difficult, because it's going to the back, all right? And then the third part of the subclavian is basically from the lateral border of the anterior scalene to the lateral border of the first rib. Okay. So third part of the subclavian, you can ligate, all right? Because majority of your branches have gone off. Your vertebral artery, your internal mammary, your thyrocervical have already gone off, all right? The most important branches, I think, of the subclavian are the vertebral artery, because it contributes to the posterior circulation of the brain, and the internal mammary, because, for example, in a patient who's had a cardiac bypass and they only have one internal mammary, you wouldn't consider blocking that internal mammary, okay? So you can ligate part 3 without really thinking about it, yeah. And there's also lots of collaterals that will then supply from the brachial, the bronchial arteries, the intercostal arteries. There's collaterals that supply the arm. Part 2, you can also ligate, okay? Part 1, I've never had to ligate part 1, but Dr. Pretorius, can you ligate part 1? But that's in austere situations. Really, I think before you're going to ligate, you should think about whether or not you can actually shunt the patient. And then do the shunt. The patient can go to ICU, be resuscitated, and then you can come back and you can do a graft, an interposition graft with the saphenous vein, or you can do a PTFE graft. And that's also, the mechanism there is usually a gunshot, because a gunshot causes major destructive injury to that area. The intimal injuries can actually extend beyond where you see the extravasation of contrast or where the patient is actively bleeding from. So those are the situations that you would do it. Ligate the vein at any level. Yeah, you can ligate the vein at any level. And also the other thing about it, if for example you're getting you're doing a sternotomy, right? And you need to, because The internal jugular vein joins the subclavian vein and it becomes the innominate or the brachiocephalic vein, right? The gateway to the chest is the innominate vein, okay? They do advise slinging the vein and moving it up, but if it's impeding your visualization, you can actually ligate the vein. In a patient who's exsanguinating and they've got a combined arterial venous injury, you can ligate the vein. The idea about doing a venopathy is that you cannot stenose the vein more than 50%, okay? And the vein is also really friable and it's flimsy. And trying to repair the vein always usually results in a lot of bleeding and the patient becomes extremely unstable. So in our practice, we are usually taught that if you're really in austere conditions, your patient isn't doing well, you can always ligate it. We only really ever advise to repair the vein if we're going to make sure that we're not going to actually stenose the vein, which, yeah, depends on the grade of the injury and how extensive the injury is.
Thank you very much.
Thank you.
Dr. Kai, to present us emergency room thoracotomy. Thank you.
There's connections.
Yeah. It's adjusting the screen. Yorgo?
What's wrong?
Let me take the time to entertain you. 2010 in South Africa, in Baragwanath. It's a Friday afternoon. A German officer from the German army, a vascular surgeon, comes to Baragwanath to get some training and exposure before he goes to Afghanistan. And the chief of surgery, Dr. Giannis, told him, you're 1 week observing, 1 week do under supervision, 3rd week you're on your own. German officer was 180 centimeters tall, bodybuilder. Most of his time was devoted to bodybuilding. And then the day comes. It's Friday afternoon. In Baragwanath is hell. Suddenly 75 wounded people come simultaneously. The German is shaking. He's in deep trouble. He doesn't know what he should do. And then out of the blue comes Kai, the speaker. He told him, relax, everything will be fine.
Than this, very small then, younger too.
Okay. So he support the German to intubate. The German intubate under support. Tell him, go to the OR, I will come with you in 15 minutes, don't worry. And he goes to the hell and shouts, everyone that can walk, go to the medical resuscitation area. From the 75, 35 gone away. Then he says, open, stand up your hands, everyone that can hear me can go to orthopedics because you have broken legs. Now there are only 10, 5 of them are dead. And after fast stroll around, he takes the 5, put them in resuscitation area, resuscitate them 5 minutes each, goes to surgery, treat the patient and the German, and everything is fine. This is Kai.
Thank you, Prof, for that very, I don't know what to say, seriously. No, good morning, everybody. Thank you very much, Prof, for inviting us to this lovely country of yours. And also thank you for your organizing this mini trauma symposium. I'm going to talk about rescue thoracotomy. Is it fine? Okay, so my talk will be about rescue thoracotomy. Are there new data? What we're doing to this patient, are we improving their outcome? What's the latest data that's telling us when should we stop or should we change techniques? Okay. I have no disclaimer. I don't belong to any political party. I usually review my literature and talk about experience that I have when giving most of these talks. Okay, if we start off with the agenda, what's the changing landscape of resuscitative thoracotomy, or what we call rescue thoracotomy? This procedure is usually done for patients in extremes, and it's daunting. It's a lot of work. Outcomes are usually dismal, but at the end of the day, when the patient comes to you, you cannot just stand there and say, there's nothing I can do. You want to do something to help and see if you can save this life. So what my talk is going to talk about, we're going to review the latest evidence. Have we actually gotten more patients from doing this procedure, or have we just made a bad situation worse? There's a lot of literature, recent literature, some 2 years ago, some around 5-10 or so, looking at the outcomes of these patients and outcome of this procedure. What is the latest evidence out there? Then also, do we need also to redefine the selection criteria? Do you do an emergency thoracotomy in all patients that come with signs of life? All patients that have been, you have started CPR on, do you do all of them? Do we have to refine the selection so we get out better outcomes? Because at the end of the day, we need to follow evidence-based medicine. If what we're doing is not improving patients, why are we doing it? So I'll start off with a case scenario, and I want to see how you guys think about this, and then from there we'll take it. We'll see what should we be improving, and what does the literature say. So there's a 20-year-old gentleman that came into a trauma unit after being stabbed. He's got a single stab on his chest. He was initially conscious en route in the ambulance, but agitated, but became unresponsive as they approached the hospital. On arrival, he's apneic, pulseless, and has no cardiac activity. The pre-hospital team reports that transport time from the incident and time of injury was actually only 8 minutes. And these are important, very important information for where we're going in the new criteria for doing these procedures. You are the trauma team now. You're ATLS trained. Hopefully you've gone to the DSTC course. You know what to do. And as a senior surgical resident, you're prepared to perform an emergency room thoracotomy. What is the primary therapy? Why are you doing this thoracotomy? Any ideas? What are you trying to achieve? Remember, this patient had a single stab to the chest, comes to your emergency department within 8 minutes. Initially was responsive, but then later on lost consciousness. So the most vital information there is the single stab and the time for them to arrive to you. So what is the primary aim? So are you doing it to relieve pericardiac tamponade because the stab is in the cardiac box? Or are you doing it to perform an open cardiac or direct visualizer heart to guide the administration of epinephrine or adrenaline? Or the other option is, are you performing open cardiac massage and directly visualize the heart to give or administer epinephrine? The last option is to perform a rapid pulmonary thrombectomy to control air leaks and bleeding from the potential lung. So what are the indications? What are the aim when to decide to do emergency thoracotomy? Are the online people also voting? Yeah.
The audience from online, if it scans on their screen this QR code, they can vote also. Everyone that has a mobile phone and internet connection, you can vote.
Okay. Remember, we're going to carry on the rest of the talk on this case scenario. So let's go on and see what were the initial aims. So most of you are doing it to relieve pericardiac tamponade and directly control the source of hemorrhage from a likely cardiac, because you've got a single stab to the chest. It's on the left side. It's on the cardiac box. So that's the most obvious injured organ in that patient. So if you look at the literature, what it says that the initial emergency room or resuscitative thoracotomy was done actually for primary pericardiac component and controlled cardiac hemorrhage. That was the initial goal for. But then later on, we found out after opening a heart, you could do other things. And literature shows that if a patient has a pericardiac component, these are the patients who actually do well. These are the patients you actually can save. Okay? The other indications, and this is usually for patients who arrive with blunt injuries, is if a patient comes to you and you've witnessed a cardiac arrest with a blunt injuries, you might want to do what you call internal cardiac massage or defibrillate, which is more effective than your external cardiac massage. That was the other indication for these thoracotomies. Then the other indications were to control intrathoracic hemorrhage, for example, great vessels, the pulmonary, and this might need a hilar twist. We don't advocate hilar twist. It has a lot of complications. We actually advocate just clamping a hilar. If you see a source of major bleeding from the pulmonary vessels, clamp the hilar. Don't twist it. And like I said again, these are taught quite well in the DSTC course that we have going out in Greece. Other indications for emergency or what we call rescue thoracotomy is to control air embolism, which is very rare, we do it for that, or to cross-clamp the aorta for distal vascular injuries, especially abdominal injuries. So if we carry on with our quiz, which of the following statement is more accurate regarding the indications for proceeding with a resuscitative thoracotomy? We want the most accurate statement. The first statement says it indicated when a witness loss of vital signs, because now all these what you call symptoms and signs now have helped us change and improve our patient selection. So is it clearly indicated when you actually seen loss of vital sign, but it is futile and contraindication when the absence of signs of life at the scene and a prolonged. So I mean, if the ambulance brought the patient to you in like half an hour, and in the ambulance they were resuscitating the patient, is this a patient that you would want to open their chest and do a resuscitative thoracotomy? And the other indications, when the mechanism is penetrating trauma, the presence of pre-hospital CPR mandates an attempt to salvage regardless of duration. Does time affect when do you decide to do the emergency room thoracotomy? Or is it contraindicated when the patient has a traumatic pericardic tamponade and posterior lateral thoracotomy in cases should be attempted? And the last option is it indicated in case of prolonged CPR? See, these are the words that I want you to emphasize and think about. Prolonged CPR, time of witness arrest. Are they important when you want to choose a patient you're going to resuscitate? So the actually new data, which I'm going to talk about, this is what the new data comes out. This is a good article. This was the first major one that came out reviewing, it's a meta-analysis on the approach selection for emergency room resuscitation. And what are we actually trying to achieve? It was done in 2015 by the East Association of Surgical Trauma, and they came out with this overall survival rate from their review, literature review was like 9.6 to 10%. 9.6 or 10% of these patients who had resuscitative thoracotomy actually survived. And it's usually the penetrating ones. And if you dig into the article, what they say is, out of these 10 to 6, which are usually the penetrating one, only 90% of them came out with no neurological defect. But if you take the ones with the blunt injuries, the rate is much lower. Blunt injury, only 2.3% of your patients survive. Now, would you want to do a procedure which has its limitations, its side effects, to save 2.3% of the patient? And out of this 2.3% of the patients that you save, only 50% walk out of the hospital. That means they're neurological intact. Now you see the data telling us something. Should we actually be doing this for every patient? Should we streamline our selection protocols? That was the neurological outcome out of this patient. So 90% of those ones that survived from the penetrating injury actually survived. So there are certain patients this actually gives you a good outcome, a relatively good outcome. So our next quiz is, so then which of the following is a definite contraindication for rescue thoracotomy? Hypotension, hypoxia, prolonged cardiac arrest, or tachycardia. Which one of it is an absolute contraindication? There you go. You see, I've been talking a lot, and most of the time you hear me saying things like time is important, how long you've been in resuscitation, mechanism of injury is important, but literature has showed a prolonged cardiac arrest has futile outcome for any resuscitation thoracotomy, be it penetrating or blunt. Yes, that's the right question. So patient with hypoxia, you can actually do it, even tachycardia. Those are the indications. And these are the two major associations that have digged in the literature, is the East Association for Surgical Trauma and the West Traumatic Association. And they have looked at the outcomes of these procedures. If you look at the East guidelines initially, there were many concentrating on signs of life. If there's signs of life, you should try to save the patient. But that was the East guideline. And what they were saying is, for any patient, and even the blunt cases, if there is observed signs of life, which include pupillary reflexes, spontaneous ventilation, cardiac activities, if it is witnessed, this patient might need resuscitative thoracotomy. But the West trauma guidelines, which was reviewed recently, showed actually the most important prerequisite of this is the duration of pre-hospital CPR. What they're trying to say is when the heart stops, when there's no itch, for penetrating injury, if it's less than 15 minutes, your outcome are actually good. But if it's beyond 15 minutes, if the pre-hospital CPR has been carried out beyond 15 minutes, resuscitative thoracotomy, irrespective of the injury, the outcomes are poor. And for blunt injury, they actually went down. They say if the patient is resuscitated for 10 minutes, outcomes for more than 10 minutes, outcomes are dismal. And then when do you stop? There's this other retrospective studies that was done in between 2017 and 23, provided powerful practice-changing data on when is it futile to actually do resuscitative thoracotomy. And they found out if you had patients with these three triads, regardless of injury pattern, their outcome is dismal. If they come in fixed and dilated, if they come with no signs of life, or if pre-hospital CPR is in progress, their outcomes usually dismal. And also what they recommended was prioritizing initially pupillary response is the most critical differentiator for futility assessment. And also adding witness arrest. So within patients who you have actually witnessed, that means the arrest has been witnessed, the guidelines say the futility depends on the time of witnessing the arrest. Another paper, this is a pre-hospital, this was done by the London Ambulance Services, and it shows that 2.21% of arrests The survival is 21% if the cause is cardiac tamponade. In the UK, they actually have doctors who are able to do resuscitative thoracotomy on scene, and they say 21% of them, if the cause was cardiac tamponade, it was successful, but the success dropped to 1.9% if it's actually bleeding. If the cause is bleeding, multiple gunshots, stab, if the actual cause of the arrest is due to bleeding, success had dropped down to almost 1.9%. And no survivors if arrest to intervention time exceeded 15 minutes. So you see now, time is usually now a factor. You need to decide, these patients who come to you, what is the time actually, how long did they arrest before you could start intervening? So their recommendation was, the time to stop is no patient achieved return of spontaneous circulation after 15 minutes. So when you're actually doing the procedure, if you carry on for more than 20 minutes, none of the patients achieved durable return of what you call spontaneous circulation. So also the duration of the procedure itself also matters. And they say action of point is if return to spontaneous circulation is not achieved within 10 to 15 minutes, you should actually stop the exercise. And now if we continue with our case again, so now you're actually performing the procedure. You've opened the chest. What you see is 150 mils of blood under tension in the sac, in the pericardium. You've opened the heart. The heart begins to beat spontaneously, but it's empty. Now you have identified a 1.5 centimeter stab wound in the right ventricle that is actively bleeding. What do you do? And these are your options. Do you suture the myocardium there in your emergency department? Or do you extend the incision into a clamshell? Do you put a Foley's catheter and try to stop the bleeding? Or do you put your finger on the bleeding and inject adrenaline to help the the heart start beating faster? Yes, so a lot of us would definitely actually try stopping the bleeding, and one of the best way of stopping the bleeding from a stab head is actually putting a Foley's catheter in and ballooning it and stop the bleeding. Yes, that's the right answer. And those are the one who's leading. 3 out of 5. So now what actually, let's go through what actually you need to perform a resuscitation. You actually do not need a lot of equipment. It's not a full theater thoracotomy set. The instrument actually you need, and make sure that one of the problems with these procedures, they are highly infective. So make sure that you have appropriate equipment before starting. This is supposed to be sterile procedure, but depending on how quick you need to get in. Okay? Now to open the chest, what actually you need is, it's freezing, sorry. It's not moving. There you go. You need a blade, a long blunt dissection forceps, a heavy-duty surgical scissors. That is all you need to open the chest. And ideally, what you would need to retract, it's stuck. Again. Sorry. Yeah, there you go.
You have to click on the black, not on this.
No, okay, on the black.
On here.
Oh. So definitely you need a rib retractors, a finiscetto, a jiggly saw. These are the rib retractors up there, the finiscettos. And then to cut through, if you're gonna need to cut through, you need what's called a jiggly saw, and lung retractors. Okay, and once you're in, definitely forceps, suture material. If it's a laceration, staplers comes in handy, Foley's catheter, aortic clamp, depending what you're gonna do, if you need to actually do aortic clamping, and then also lung clamps are usually very helpful in this procedure. So what thoracotomy incisions would you do? For what's the ideal thoracotomy for resuscitative thoracotomy? Is it a lateral, anterolateral thoracotomy, a clamshell thoracotomy, posterolateral thoracotomy, or a transverse thoracotomy? Which is ideal for rescue resuscitation thoracotomy? Okay, that was an easy one. So the surgical technique, the ideal one is usually the left anterolateral thoracotomy, but it has its limitations, which exposures to the right side of the chest is limited. So some people go straight forward, what's called a clamshell, if you have multiple gunshot wounds. And then it gives you excellent exposure, and it's usually ideally for trauma surgeons who dealing with controlled hemorrhage that are requiring aortic clamping. So between these two, literature says that anatomical studies have shown that the clamshell is actually an ideal for people who are inexperienced because you get a better view of the chest. But what we usually tell people is usually a departmental decision. But for people with poor surgical expertise, the clamshell is favorable for maximizing control and visualization, especially if you don't know the injury, where the actual injury is at. The other option is comparing the posterolateral. Why don't we do the posterolateral thoracotomy? Because you know that gives you a better visualization of the whole chest. But for emergency, for a patient in extremities, you need to see which one will get you quicker, because remember, for the posterolateral thoracotomy, there's positioning of the patient. It might take longer to get in because of the muscles at the back. The patient is usually put on a lateral decubitus, and it's usually used for an elective procedure and not for the emergency. So the left lateral is usually a crash and grab when you want to go in quick, while the posterolateral is usually a control procedure when you actually have a stable patients and it's an elective procedure and it's controlled. That's what are the two main differences between these two procedures are. And the pitfalls that you should look about is when you're preparing the patients is in the incision. The usually incision starts around the sternum and has to go all the way back to the posterior axillary line. This gives you a better visualization, better way to actually open the left chest. The other thing is sometimes you have to transact the sternum with heavy seizures to change the left lateral thoracotomy to a clamshell. Then if the patient has a pericardial tamponade, forceps and opening the pericardium, you have to make sure you don't resect the phrenic nerve, so your incision should be longitudinal, caudal, cranial, and not transversely. Other techniques that you should watch about when you're trying to clamp the aorta, make sure you are able to release the lung all the way up, anterior and posterior, so that you can actually visualize the aorta, dissect it anterior, bluntly and posterior, and clamp. So directly clamping of the aorta is very important. But the future is we have removed some of the cohorts of these patients that actually do well. but because of the morbid, left thoracotomy, these patients actually, their morbidity and outcomes are dismal. So there's this thing called REBOA, which is the resuscitative endovascular balloon occlusion of the aorta, which has taken some of the indications for, from the emergency room thoracotomy and given them a better outcome. So it's a procedure where you access the femoral artery, go into the aorta. The aorta itself is divided into three main regions: above the celiac trunk, between the celiac and the renal vessels, and below the renal vessels. And usually these procedures, when you want to occlude the aorta, you go above the celiac trunk. This has taken some of the cohorts of the patients that actually do well, which are patients who have distal bleeding, and you need to do a proximal control for one reason or the other. And then last quiz is complications. For any surgical procedures, there are usually complications. So what do you think, are there any neurological complications of resuscitative thoracotomies? Okay. Actually, some of the patients actually get spinal cord injuries. And the reason they get spinal cord injuries, the spinal cord is usually supplied by a watershed area which gets its blood from the intercostal arteries. So when you go in through the chest, through a lateral thoracotomy, or when you start dissecting the aorta, some of these intercostal are disrupted. So some of the patients come out with neurological defect. So there are neurological defects in these patients. And then the other common complications, I see it's the same people. There we go. The other common complications for this procedure includes iatrogenic injury of the phrenic nerves, infection, mediastinitis, because most of the time these procedures are not done in a well controlled manner, ischemic of the distal ischemia from prolonged aortic clamping. These are some of the other complications. But also let's remember there are also complications to the provider. Sharp injuries, as you've seen on the video, it's usually something very drastic. People are all over the place, so there's a high risk for sharp injuries which might lead to infections, blood-borne injuries like HIV, depending on the patient's immunity. These procedures have high risk for all these complications. So in summary, what I would like to say is, with regard to emergency room thoracotomy, is there is a paradigm shift, especially in the patient selection. Time is usually of arrest is very important. We are trying to remove some of the cohort of these patients so that we get a better outcome, which include or with procedures like the rebow. Then also remember, know when to stop. If you're doing this for more than 10 to 15 minutes, and you don't have return of spontaneous circulation, these patients do dismally. So you might as well stop. So time to stop, not only time when to do them, but time to stop is very important. Then the best patients, the outcome is best is patients who tamponade, and do not hesitate to perform a clamshell, especially if you're inexperienced in doing the left lateral thoracotomy. Any questions?
Thank you. Would you kindly describe what sort of preparation is necessary for the emergency room in order to perform a resuscitative thoracotomy in the emergency department?
Okay. The important thing that you need to think about before performing this procedure is, one, first, can you perform the procedures? Emergency room thoracotomy should not be done just because you've heard it. You need to have experience in doing it. That's number one. Number two, do you have the equipment to perform these procedures? Like I said, the equipments are usually not many. It's a few important things that you should have, including the retractors, before you start performing this procedure. So can you do it? Do you have the equipments to do it? Okay, and then the next thing is, if you're doing it there, where is the patient going? Because if you're doing an emergency room thoracotomy, and then you have to transfer your patients for a long distance, like we say, that usually the outcomes are futile. Okay, and then the third one is the indications of doing it. Do you have the appropriate indication of doing this emergency room? Because not all patients do well, so you have to choose your patients if you want positive outcomes.
And one more thing that is needed, change our mentality. The mentality of the Western world is minimally invasive. In such a case that the patient dies, you need maximal invasiveness, maximal boldness from the doctor in order to save a life. This is something that must change.
Okay. Thank you for the wonderful presentation. Any advice for the ambulance crew could you give, or for the doctor in the rural centers?
The advice that we usually give them with regards to this patient is they should actually time, because remember, one of the things that we're changing on the indication for this is time of witness arrest. That information that the doctors, that the patient will receive, he has to actually decide, is this patient that he should go ahead and go all the way if the patient arrives in extremes or not. Okay, so time is a very important factor. So calling in and telling your emergency department that I've got a patient with X, Y, and Z, and I'm coming across, he's in an extreme, he might decompress, and this is the time. So timing is usually a very important fact that you advise. In some countries, a lot of the first responders, they are doctors within the set. So some of these first responders actually have people who are trained in doing, like you saw the research done by the London ambulance, where they actually, so making sure that you have the appropriate equipment in your ambulances when you go out to calls that are usually for penetrating trauma or even for MVA is advisable to make sure that you have the appropriate equipment in your ambulances.
Thank you.
And one more thing that we should notice, in the Venezuela invasion from the Americans, there was one soldier that was wounded in the chest, and on the field a doctor do a thoracotomy, and the guy is now alive, and he also took a medal from the President of the United States, 28-year-old, alive with thoracotomy on the field. So these things can happen and happen effectively, but we need to have preparation. We need to have schools that teach these things, and the University of Athens is evaluating the possibility to create a school for paramedics, official school, and augment the training and their capabilities on the field. Next speaker is Rian Pretorius, a good friend, the mental son of Ilias Degiannis and the chief of Baraguanath Trauma Directorate for years now. Extremely talented surgeon. He will speak about how we organize our emergency departments and what is the role of the trauma team and how we activate them and what role each of the trauma team players play. Thank you, Rian.
Okay, so while we wait for it to load, you guys can relax. There's no voting since I got a topic about trauma systems. So you guys can relax. There's nothing to screen and to vote. So as Panteli said, I'm working in a private hospital, Millpark Hospital, and I'm also working in Krasani Baraguanath Hospital. So, I mean, we live in a very beautiful country. It's like a country that's got like almost everything. But actually, unfortunately, one of the things that we are not so proud of is our crime and our trauma statistics. So we, like in some states in South Africa, they said we saw about 25,000 trauma-related deaths a year, which make us actually qualify for low-grade civil war. So most 1 million of trauma cases a year are seen in the country, and most of them actually end up not in the right facilities. We are a country full of penetrating trauma. So where I work in Chris Hani Baragwanath, we see about 80 to 120 P1s a week, and we see about 400 to 600 P2s and P3s a week. And of that, 60% is penetrating trauma. So it's quite a significant amount of trauma. So, and it mainly is young and productive, and especially males in South Africa that is involved in trauma. But I must say, like, with the bad news of what is happening in South Africa, it's also the good news. We just finished teaching DSTC, and it is I'm very proud to say that most of the DSTC instructors from Greece has actually worked in Chris Hani Baragwanath Hospital. So it became that we make actually a difference, not just in South Africa, but even beyond South Africa. So South Africa realized that we need to do something about our trauma, and we have to put trauma systems in place. So I benefit from a lot of these people that you see behind me, Professor Hardcastle, Beaufort, Almin Stein, Prof. Moyeng, people who actually set trauma systems in place, because they realized that if we want to save more lives, there must be systems in place. And they sort of slowly started, so we had the Trauma Society of South Africa. I left South Africa on Tuesday. On the Monday, I was driving around and do accreditation of hospitals. So they invite us, we go to the hospitals and say to them, you are level 1 or level 2 or level 3 hospital. So level 1, there's not a lot of level 1 trauma hospitals in South Africa. There is from training hospitals that's not accredited as level 1 because it's more administration. It's basically Chris Hani Baragwanath, Charlotte, Albert Lutuli, Groote Schuur, Tygerberg, and in Pietermaritzburg also. In private hospitals, there's only about 5 private hospitals that's level 1 hospitals. And then you get level 2, who sort of like look after trauma patients, but not as serious trauma patients. So do we need trauma systems? You know, for us in South Africa, there's chaos, so let's try to organize chaos. Let's try to make it something that we can actually make a difference. And then the Trauma Society started accreditation of hospitals. So you go to a hospital and say you're level 1 and level 2. But you have put a criteria out, so you have to tell all the level of hospitals, level 1, this is your criteria to become a level 1. And the reason they did it is that when a patient ends up in the right hospital at the right time, it makes a difference in outcome. It's been shown that they make a 15 to 20% increase in survival, and that you can actually decrease your preventable deaths. And that's where the most important part of it is. And I know when you put trauma systems in place, people think that it will cost a lot of money. On the long term, it will save you money. I mean, to get people, to return people to be society as functional humans, actually save the government money and not necessarily cost them more money, although you do have to invest to get back, like anything else when you want to make money. So a lot of the trauma systems come actually from America, where they put in trauma programs and trauma systems. And then in South Africa, we decided, let's do the same. And what do you want to achieve? You want to get the right patient to the right facility as quick as possible. So basically, we don't want to see in the level 1 hospital, unfortunately, in Chris Hani Baragwanath, because there's nothing else to take the patient away. But we want to see, so a level 1, a gunshot abdomen to come to Barra and not to go to a secondary or a district hospital and then refer to us, because then it will take another 4 or 5 hours, while if the patient came directly to us, it will make a difference in outcome. So we want to see the right patients to come in the right time and as quick as possible. And that is actually what we want to, and that will improve outcomes. So we definitely decided that definitely makes a difference, and we want to support it. So what you want is, you want your hospitals also to realize which is the hospital that you need to refer to. So you want your level 2s and your even your district hospitals feel comfortable to refer to a level 1 hospital and to have people in charge of the level 1 hospital. But for level 1 hospitals, what you need to do is there's also a lot of things that you need to put in place. You need to have a data bank. Because the data bank, you can actually reflect on the trauma that you see. You can actually teach what you see. You can actually use it for research, because one of the major components also is that you must have research also and produce research. You must have injury prevention as a plan also. You know, you can't just think that we're all just going to treat trauma if you don't want to do injury prevention. And injury prevention is a very simple, you know, we go out to hospitals, we go to schools, every year on World Trauma Day, we've got like a program to teach people about fires, because in South Africa, fire is a big problem, so especially because we're a poor income country. So what we have is that we have, in the winter months, we see just a spike in fires. You know, we want to educate. We also need to educate our politicians, unfortunately, about how much money is spent on trauma, because everybody look at all the other things. They look at oncology, they look at any of the other things, but people don't spend time to look at trauma. And I can tell you, in my hospital, we got like 120 beds just for trauma a week, every day. So we have got 120 patients that come in, and those patients just stay, or when we see them, you discharge 20 today, tomorrow you admit another 30. You discharge, then you admit. And the other thing that I think where we actually should also educate it, in the government facility, the government sector that we've got, we don't have rehabilitation centres. So without rehabilitation centres, we don't get people that we can educate, a paraplegic or quadriplegic patient, to go back to their family. Now, most of our patients in Barra come from poor communities, so they don't have the income for a wheelchair or income to teach these people or learn how to change their house, to take away steps, or to make a toilet big enough so they can actually go to the bathroom. So I think it's very important that it needs to be overall education, and the only way you can actually save money is to do all of these components. So I'm not going to go through the helicopter call-out criteria. Part of it is as we're also involved a lot in the pre-hospital. I'm still a consultant for one of the Netcare 911, the helicopter that you see here in front of Milpark. And just to give you the differences also between the hospitals. So Barra is a government-owned hospital, so we've got, like as I said, we use about 120 beds a day. We've got an 8-bed ICU that we can use. In Milpark, we've got about 30 ICU beds, 8 burns ICU beds, and 8 trauma high care beds. Okay. And that's the difference between private and that you've got a lot more resources to play. But what we've done is, because we want to give our best care for our patients, is we set systems up. So here's a telegram system they've put in that when they're being activated, they can send you all the information. They say, helicopter's been activated, we're going to fetch the patient, helicopter landed, scene, this is the vitals of the patient, we expect to be back at the hospital, and the person that will be there to receive the patient will be the trauma surgeon, will be waiting for the patient when the patient arrives. You can see they send you all the vitals and everything else. As I said, I'm not going to go through all of the flight criteria because there's a lot of them, but obviously, like for us, as any penetrating trauma, severe head injuries, burns patients, prolonged entrapment patients, patients that's unstable on scene, as patients that you want to get flown to us. Electrocution is also one of it, so I'm not going to go through the medical one, so it's not my problem, someone else's problem. But the other thing that you can use sometimes with helicopters, you can get expertise to the patient. You know, like I'll never forget, there was one that they referred the patient to me, a husband threw petrol over, and I said, do you not want to fly the patient? No, they want to fly the patient. I said, do you not need to intubate the patient? No, I don't want to intubate the patient. Eventually, when the patient arrived at us and we wanted to intubate the patient, she had full thickness burns on the face that we could not open her mouth. And if they intervened earlier, it would have been much better. And I think the doctor there was just too scared to intubate. And instead of calling expertise, because our helicopter crew is usually advanced life support, and we don't fly with doctors anymore, but all of them can intubate. It's part of their skills they've been learned. So I think sometimes you're in an area that you actually do need to get advanced life support to intervene or intubate the patient or put lines up that they struggle to get it. Sometimes it might be used for difficult access. So when people are on a mountain and stuck in the mountain and they need to go down, they may usually send a military helicopter. And then mass casualties, we also have been using the helicopter. So a few years ago, there was a train accident in Soweto. There was 300 patients in the train accident. They used the helicopter because obviously what happens with a mass casualty, there's lots of ambulances, there's lots of traffic, poor access. And what they did is they came and picked up the P1 patients with the helicopter and took it to an area out. We were supposed to get all of the patients. They took it to areas, took it to Joburg Gens or Charlotte to relieve us from all the patients. So we don't get the P1s and P2s that will take a lot of effort. We had to deal with all the other patients that came in. So you can use it as a resource to distribute in mass casualties also. So the late Dr. Vicky Jennings did at our first pre-hospital Raboa. She was called to a scene where this young boy he's 18 years old, was actually trying to push a grinder that grinds like corn, and he was trying to push it down, and his leg got caught in it. You can see on this side, that's the leftover of his leg. So they were concerned to take it. They couldn't get that machine off him, and they were concerned to get the machine. As you can see from the previous picture, there's no space to put a tourniquet or anything like that. So they were very worried about actually releasing him without adequate control. So they flew Dr. Jennings across there. I'm not going to go through that one. But they flew her, that was during the COVID time, to go and put a Roboa in. So she did a Roboa pre-hospital on the other leg that was available. So you can see, I'm just going to keep quiet so you can listen to it also.
Down would be this first spot here. So you need to thing out by 1 centimeter, just the tip. That's it. Gonna have to mark it or slick it. Suture it in.
How big is the time? Again? The watch on here? Yeah. 19.5.
1450. 1457.
So
No,
just
I'm
give
like
the time when
14.
you put the Roboa in so that everybody knows.
Relative resistance at 12 minutes. Okay, I've locked it in place. So just give me a stitch.
Okay, and then they secure the Roboa. And then here is when the helicopter is leaving. So the one helicopter is the helicopter with the patient, and the second helicopter, you'll see it now. And the second one is the one they fetch it from the hospital with all the equipment to go and do it. So they basically use the pre-hospital system also to actually get to the expertise to the patient. And this is how the patient's leg looked when he got to theatre. Okay. And he actually survived and he went home eventually, and he's doing very well. So for us, it's like when we work in the hospital, we really do get a lot of referrals, because that is how the trauma system should work. That your secondary hospitals believe and trust in the systems that you put in place, and then they bring patients to it. You can see, yes, 3 helicopters landed at the hospital. So literally, we get referrals from probably like, I would say, probably almost 700 kilometers away from us. People will still refer patients to us because they know that we've got trauma systems at work. And I think this is how it should work. You should identify the hospitals that can deal with the polytrauma or severely trauma patient. Because at the end of the time, at the end of the day, it's time to the injury and time to definitive care make a big difference in outcome. You know, the longer it takes to give a patient definitive care, and especially so with penetrating trauma, but also with blunt trauma. So what we do is, even when we, in a part of a level 1 trauma system, is that they record our response time, record our primary survey time, record our time to also how long the patient spent. And you want to spend less than 60 minutes in resus. That includes CT scan, everything. So it's literally a patient come in, we load doc, so we've got an X-ray machine top to bottom from the start of the patient's table, and then you do your primary survey, resus the patient, scan the patient, and then the patient gets admitted to the trauma ICU. And what it's supposed to do is, on the slide, the date's a bit older, but what it's supposed to do is that when people buy in the system, you can see that progressively more and more people referred patients to the level 1 trauma center, because people buy in the system and they realize it makes a difference in outcomes. So if you look that basically there was a growth in P1s from 2012 to 2014, every year growth by the time it was from 2012 to 2014 by 35%. The growth, because then people sort of realize this is what they want to do. And the only way you can prove it is in outcomes. So when you look at the injury severity score, and then you look at unexpected survivals in that time, so people with the injury severity scores that you thought will never survive, and 94 of those patients actually did survive. And that is the only way you can prove to people that trauma systems do work. And it's actually, and I think the more we can show that, the better that people will trust it. But when you work in a level 1, you must be ready for everything. On top is Max the gorilla. He got shot at the zoo just next to, or close to Mill Park. the robbers were stealing a house, they jumped over and then they shot the gorilla. The gorilla ended up in Milpark, was actually resuscitated by one of my colleagues, Prof. Plani at that stage. And then the other one is also from the zoo, complained of headaches, so they sent him for MRI also. So I'm not sure how he's got MRI. But in the way that where we work, we see unusual stuff. So this is a patient who was attacked by a leopard. So a leopard is probably one of the most beautiful creatures you'll ever see in the wild. But it's really very difficult to see, and everybody loved him. But he went out smoking, and while he was out smoking, got attacked by a leopard, and he came to us. And then he also had the aneurysm of his internal carotid artery that we had to stent. Burns patients, we see lots of burns patients that get referred to us because we got an 8-bed burns ICU also. So we received the patients, we stabilized the patients. That eschorotomies I did in the emergency department for this patient because we couldn't ventilate him, and his arms was also full thickness burns. This is a gentleman that fell in the mine shaft and fell on the mine shaft, and he arrived to us like this. He was transported on his side. With that stuck into him, we went to theatre, we pulled it out in theatre and did the laparotomy and ended up with a nephrectomy. 2 years after he was discharged from us, he ran the Comrades Marathon. So for those who don't know, the Comrades Marathon is an ultra marathon of 90 kilometers. He ran 2 of them since his discharge. So we do see unusual stuff, but I think we've learned through times how to adapt and how to manage them. But how does it work? You know, we can only make a trauma system work if it is a teamwork. And the teamwork starts from the hospitals that support you, from the emergency personnel identifying that it's rather to drive 5 minutes late and come to level 1 than to go to the hospital just around the corner. It makes a difference. The second thing is that you must have a leader. How it works with us, the trauma surgeon is the leader. So we accept any inter-hospital transfer, so it comes through trauma in Chris Hani, Baragwanath and Milpark. Every trauma patient comes through the team leader, and that will be the trauma surgeon. The trauma surgeon will then be the one who see the patient, resuscitate the patient, and send it out or then start calling in others. And you must have people dedicated anaesthetist that's dedicated trauma. We do use emergency medicine physicians also. They also help us for stabilization. But ultimately, the biggest thing is that the patient belongs still to the trauma surgeon. The last thing you want to do is people transferring, and people work in Milpark Note also, or in Chris Hani, Baragwanath. If there's a head injury, they say send it to trauma, because there's no point of accepting a head injury and he starts bleeding from a spleen that was missed in a secondary hospital. So we clear the patient first, and then we can say, okay, now it can be taken over by another specialty. We need neurosurgeons, orthopedic surgeons, plastic surgeons, vascular surgeons, maxillofacial, we need all of them. At the end of the day, I think that probably the biggest difference that you do have is the nurses in what you deal with also. So the nurses in the emergency department need all to be trauma trained. If they're trauma trained, they make your life a lot easier. So what we do is, the moment the patient reach the emergency department, there's a pager going off, and even the nurses from trauma ICU come and see your patient, see if the patient's ventilated, see if your patient's on inotrope, see if what they need to prepare for the patient. So all of this make it like a team that work. And in theatre, when you do an unstable patient, you need staff to know what is damage control. You need staff to know what to cross-clamp the aorta, or what is a vascular procedure also. As I said, you do need people that support you. So this was a guy who was in the MVA, the carotid cavernosus sinus fistula, and was picked up by the radiologist, and then the angioembolized also the carotid cavernosus sinus. I've got no clue what they did, but they did it, and it worked. You need vascular surgeons for people who's got aortic dissections, that they come and stent your aorta for you. And the other thing that we also realize that makes a big difference, some of these polytrauma patients end up 3 or 4 days down the line that they deteriorate from a respiratory point of view. We almost have, I would say, at least 1 to 2 patients a month from trauma that's in the cardiothoracic ICU on ECMO, because we can't ventilate them. So if you don't have that available, they sent me recently a young boy, fell off his motorbike, he just had a clavicle fracture, and then he started deteriorating. When he arrived to us, his SATs was 65%, and we had to put the ECMO catheter in the resus form and start ECMO in the resus form. And he actually was discharged also. So we are very dependent on everything else to support us, but at least we've got the resources in the level 1 hospital. I think that's the main thing, that you must make sure that your hospital is equipped to deal with most of these things. The guy with the leopard attack, they basically rebuilt his face with, they made him some facial bones and they put a flap on it also. And the gentleman with the carotid cavernous sinus thrombosis came back 9 months later and his CT scan brain is absolutely normal. So as I said, there's many pieces to it, and the only way that you can actually fix it is that you need people that push for it. You need people like Pantelis who's pushing for trauma. You need Fortuna's to push for trauma. You need people that actually are willing to do it, because it's not the best lifestyle. It's not a glamorous lifestyle. It is hard work, but at the end of the day, we would do it all for our patients, and the outcome is the one that we actually strive for. So just a last message for all of you. Time changes everything. That's what people say. It's not true. Everything changes. Doing things change things. So you can't say time will just change it, but doing things actually change things. Thank you very much. Any questions?
Briefly, you saw Vicky Jennings in the field.
Yes.
Since we have the ambassador still here, can you say a few words about Vicky, and then we do the formal tribute to her?
Okay. Well, I did something formal also, so if you want to present later. So Vicky was my dear friend. I know her for 13 years. She was my deputy also at Krishani Baragwanath Hospital. She was ambassador for female surgeons also in trauma. I think she was a mentor to most female registrars. There's nothing that Vicky couldn't do, like when she used to operate, she was a phenomenal surgeon. She was a phenomenal inspiration for people. She did the first out of hospital Raboa. She did, as I said, she was internationally and nationally very well known. So she was really, I think for us, for traumas in South Africa, she's irreplaceable. I think sometimes, you get people that you can't replace, and Vicky will always be there. I think she's, like every day, I think sometimes she's just going to walk in and say what happened while I was gone. But unfortunately, it was one of the saddest days, and it's now almost 2 years at last that she passed away.
Okay, thank you. Thank you, Rian. Any questions from the audience here on the internet?
Dr. Mazibuko, a very good friend of us. We know him since 2016. He's a very well experienced pelvic surgeon. We are very happy to have here Tammy. We had 2 days an excellent course for orthopedic pelvic course. We are going to establish a new fellowship for Greek orthopedic surgeon, working with him for 3 months.
Let us just recognize the...
Thank you.
Professor Vassiliou, Professor Koluvaris, good friends, Her Excellency Ms. Msenga, colleagues, good morning. Our talk for this morning is unstable pelvic fractures, and so I've chosen this talk because it's a very common problem, a very costly problem to the health systems around the world, certainly from our part of the world, and certainly what I've seen in Greece, also the same thing. Just by a show, I just wanted to know how many of you have treated or seen any, have treated patients with this problem. If I can just have an indication, please. I'm aware we have a lot of surgeons in the room. I know we have maybe general practitioners. Even if it's just, having seen a patient.
It's very fast to go back once again, because it will very fast. Back once again. Okay.
Yeah, can start there. It's not voting.
13, 14, 16. You can press and you see the result.
Okay, so I see a lot of us have seen this problem, a lot of us have treated it. From my part of the world, where I come from, we practice in Johannesburg. We practice in Johannesburg, which is over there. I'll use the mouse, it's fine. And we have a huge catchment area of the greater Johannesburg metropolitan area. I work closely with my friends from Baragwanath. I'm slightly north of Baragwanath, where the actual work happens. And so my hospital is called Charlotte Maxeke, which is in the center of Johannesburg, and that's it there. So our catchment area takes about all of that region from Pretoria. We see patients from neighboring countries all the way to Mozambique and Botswana. And so we have a lot of referral centers, and we try to, streamline and channel that trauma centers that Rian was talking about earlier. What is the size of this problem? So pelvic injuries can happen to any patient, any age of patient. According to worldwide literature, it peaks at around middle age, 35 to 45 years. That being said, we've seen patients all the way from pediatrics, and I'll show you a few examples, all the way to 90-year-olds who present with this problem. Because we see a lot of trauma where I come from because of road infrastructures, the violence that my colleagues have touched on. So those injuries, unfortunately, are very life-threatening, and when they do happen, those patients need to be streamlined to where they can get help as soon as possible, otherwise mortalities rise. You do need a team around you that Rian has touched. We work a lot with trauma surgeons, we work a lot with nursing staff, we work a lot with vascular surgeons, urologists, are friends of ours because of the nature of the work we do. How do the patients present? So they can present in a variety of ways. One of the more common ways that we see are these contusions of the skin, which are very commonly seen. So something like this, where it can just be a bruise. And in inexperienced eyes, those bruises can be discarded or not taken very seriously when the underlying problem is actually much bigger. This patient presented following a motorcycle accident, and you can see he has what they call a dissort lesion. You can see if you don't do that log roll and you don't check the perineum and you don't do a first primary and a secondary survey, a lot of those injuries can be missed. So the x-rays can be innocuous, as you see there. So I just wanted to know, so this patient is now in your casualty. What is your next step? Are you going to send him home because the x-rays are not very bad looking? Are you going to admit the patient? Are you going to discharge the patient to a referral center? Or are you going to discharge the patient to a lower level trauma center? So a lot of us are admitting the patient in traction, which is a very reasonable next step to do for this patient. The next thing is obviously to pick up the phone if you're in a referral center, and especially sometimes we get phone calls just to get an opinion from a colleague. What should I do with this case? Is it okay? Is it fine to send it home, or can I admit or send to you? Some of the times what we do find is patients with this kind of thing. We discussed this during the DSTC. With a patient who's presenting very hemodynamically compromised, the patient is embarrassed hemodynamically and also not doing well clinically. When we do a secondary survey, this is what we see. The trauma surgeons at our center are very fond of pelvic binding, a pelvic sheet, because it's life-saving and it's a skill that we teach around the world. We taught it yesterday and the days before to the colleagues in the DSTC. The only thing I wanted to stress is the timeous preparation, putting off the sheet or a pelvic binder, and also making sure that it's taken off timeously and not left for 3 or 4 days on end. This patient was seen about 12 hours following putting off the sheet, and this is what the results are on the soft tissues. Although he survived, now there's an added problem of soft tissue injuries that the patient has sustained. If anyone has seen this lesion with a show, I would like to know what you think this lesion is. So this is the lesion we're talking about right here. And how serious is it, right? So do you think it's just an abrasion? Do you think it's a Moral Lavallée lesion? Or do you think it's an open injury? Okay, I see 100% of you are correct. This is a Moral Lavallée lesion and it is life-threatening, and it also speaks to a deeper problem that the patient might have. So getting down to business now, so if you are seeing these patients and in a resource limited center or country such as where we come from, even in other developed or developing countries, the importance of referral centers cannot be stressed enough, but also registries are immensely important. We were talking to Professor Vasileu and Professor Koulouvaris 2 days ago about setting up a registry for Greece, especially meant for the trauma center, which I think can improve a lot of your teething health problems that you are experiencing. So the importance again of that teamwork that I spoke about earlier. When it comes to pelvic injuries, we always use this analogy as a teaching tool to always think about them like two doors. So a pelvic ring works like this. So if this is the front of the pelvic ring over there, which is the strike side, if you go to the doors, the strike side would be the front of the pelvis, so the pubis would be right there. So the hinges represent the back of the pelvis, and so you can think about it like if you have an open book and you're trying to close the book for whatever reason, maybe the patient is bleeding, maybe the patient is hemodynamically compromised. If that open book is also fractured at the back, you're defeating the purpose by just trying to close the front without thinking about closing the back as well. A broken door analogy. And so with your start, we always start with an AP pelvis. It's very informative to us. We like to use this, what they call a plumb line. It gives you at a glance an idea of what's happening to the pelvic ring. So do you have vertical instabilities? Do you have rotational instabilities? And you will see that immediately. I'll show you in a few slides to come. If you have rotational instabilities, although I often say to colleagues, it's not necessary for you to know what the diagnosis is. All we want from a primary referring doctor is to recognize that at least there's a problem, so that they can pick it up and they can send it to us timeously. So that's the x-rays that we always start with. So going to them, there's about 3 main groups. The first one is called the lateral compression group. That's where the pelvic ring is broken from the front going all the way to the back. In a primary one or group 1, what you will have is just pubic rami fractures in the front. This is important to pick up because although on the x-rays you might see an innocuous or like an innocent looking x-ray, they are associated with intrapelvic damage such as bladder injuries, such as vascular injuries. We see a lot of bowel injuries as well. So those patients also need to be referred to a referral center. When we go to the group 2s, you can see now the energy has transferred all the way to the back. And so the whole pelvic ring is disrupted from the front to the back. This is now a grossly unstable situation that needs attention, what they call an implosion injury, which needs to be picked up as well. So that's how the patient is fixed. When we go to the most extreme of them, this is what they call a windswept pelvis. And so this one is easy to recognize on an AP film. Any medical professional, from a nurse, from a student, can see there's a clear problem. And so this patient cannot be staying in a referral center if you can't help them. They need to be referred as soon as possible. Associated injuries are what actually threatens the patient's lives. And so Pelvic injuries, one of our teachers back in Johannesburg likes to say, they never hunt alone. So they're always associated with something happening to the head, something happening to the chest of the patient, something happening to the long bones. And so those are the injuries that are putting the life of the patient actually at risk. And so that's where they need to be recognized as well. Like I said, they can present in a variety of ways. One of the other more common ways that we see, sometimes all you see is a moral lavellée and hematuria before you've done an x-ray. When you do an x-ray, you might or may not pick up an obvious pathology of the x-ray. In this lady on the left side of your screen, you can see there's a clear open book injury as well as a high dislocation of the pelvis on the right side. So clearly there's a problem, and the patient, you need to pick up the phone and phone someone for help if you're not sure what to do. Sometimes it can be very innocuous when you're looking at an x-ray, right? So this young man works at a factory, and he said he works on a crane, and he fell off the crane and he presented very hemodynamically unstable. If you look at his x-rays, it's not very grossly unstable like we saw earlier on. The fractures are very occult and they're very soft looking. So I wanted to know from you, what is your next step if you are at a peripheral hospital emergency department and you see this kind of picture and these kinds of x-rays, right? So if you look at an x-ray, I told you how innocuous it looks, and in some eyes you may dismiss the x-ray. But if you actually look at the actual patient, you can see the amount of damage the crane has done to the patient. He's going to need a lot of work to be done for those soft tissues. He's going to need a lot of debridements. And in fact, he's in trouble because he's now going to go into sepsis, and he's going to need a lot of help at a center that can actually handle those things. That's my other point I wanted to make with the slide, is that the literature is very, very clear on this. It's important where these patients are treated. So it has to be at a center where you can have plastic cover, you can have vascular cover, you can have trauma expertise and so on. It can't be at a referral, small hospitals where the surgeons, everyone is doing the best they can, but it's the wrong, I don't want to say wrong, it's an inappropriate level for that patient to be treated at that center. And we've seen and we know very clearly that the outcomes of these patients will improve if they're treated at appropriate centers. So the lateral compression we've touched upon, this is the one you will see most commonly. We go now to the second group. This is the second most common that we see. They call this an open book. The scientific term is an anterior-posterior compression injuries, where now the book is opening from the front all the way towards the backside. These are the ones that happen following motorbike accidents, car accidents, falls from heights, and so on. We do see also injuries like this happening in children. Previous literatures used to say these injuries in children are not as severe as we see. And we know now very clearly that in children you can also get these injuries. So, for example, on your screen, we've got x-rays of a 3-year-old patient who was at a back of a bakkie when the bakkie crashed. And that's how the patient presented. That's the x-ray. That is the CT scan of the same child. And I wanted to quickly just get an idea of, do we know what this diagnosis is? So let me just show you one more time. That's the x-ray, left side, right side. You can see there's a clear dislocation. I'm going to give you the answer now. Clear dislocation on the left side, clear dislocation on the right SI joints. There's a vertical shearing component on the left side. There is a complete disruption or dislocation of the symphysis in the front. So what do you think the diagnosis is? Okay, we've got a few. Combined mechanism may or may not be right. I think it's got a few of the features of all of the things. It's got a open book features, it's got a lateral compression, not so much. It's got a vertical shear feature, and it's got an open book feature as well. So the most important thing, obviously, any medical professional will look at that X-ray and they will hopefully pick up that a problem is happening and a combined mechanism is correct. So the child was immediately taken to surgery, and also external fixation is a very useful tool in pediatric pelvic injuries. The registrars at our hospitals are taught to do on the iliac wing here. The orthopods among us will know this. We discussed this with Prof. Chris yesterday as well. Or the most stable external fixation that we always teach is to do the single pin on each side, what they call a supraacetabular pin, which is looking like the one at the bottom here. So the child was taken during the nighttime, and a resident and a fellow were doing a iliac wing external fixation, which is shown on that top right picture of your screen. And so because we don't know how long it's going to be in, we don't know how long the child is going to have to be admitted, those iliac wing pins get very septic and very loose very quickly. And so we prefer the supraacetabular one, which is done, that's the drill, is showing the supraacetabular pins that we prefer. This is clinically what it looks like. You can see the child has already had a laparotomy by the trauma surgeons or the pediatric surgeons. Child is still in trouble, still hemodynamically unstable. And so those are the pins I'm talking about, and they can be left for days on end without the problem of loosening. Obviously, sepsis can potentially be a problem for them as well. This is us now definitively treating the child for her injuries of the pelvis. And so you can see the picture on the left there. That's how we drape and prepare the child, supine position, making sure that you know where your vascular zones are, and then you can safely perform these surgeries in children as well. Often we see this kind of picture, again, a patient from a motorcycle accident, and clinically this is all you see. And this was not from a sheet this time. So this is how the patient presented. It might have been a seat belt injury. It might have been an injury happening at the field as well. Often we see these gross injuries, open injuries of the pelvis. Now the mortality will go from less than 10%. And if there's an opening in the perineum, opening at the back, opening of an open wound on the buttock region or in the abdomen, the mortality now goes from less than 10% to more than 75% if not treated appropriately and timeously. This young lady, also 24 years old, was involved in a high velocity MVA, and that's how she presented. So you can see a gross instability of the pelvic ring. You can see the patient is in trouble. She's lost a lot of blood. She's in shock by the time she comes. Those who were with us yesterday and the day before, we spoke a lot about the C-clamp. Dr. Chris, this is that tool we were talking about yesterday. Very, very useful, very helpful tool. Anyone can put it on. It doesn't actually necessarily need to be put on by one of the orthopods. And so how the tool works is that the pins need to be put at the back along the iliac crest. The way to find the iliac crest is obviously clinically you can palpate it. You palpate it all the way to the back where the dimples are at the back, the posterior superior iliac spines, and then you slide slightly down from there. Clinically very easy to find it. If you are unsure, a C-arm can be used. And then you put the pins from the left side and the right side. This thing comes disassembled. So it comes in, it's a three-piece piece that comes and you have to assemble it yourself. Very easy to put together, also very quick. And once it's put on, the advantage there is that instead of opening or closing the book in the front and opening at the back, you're actually closing the whole pelvis from the back to the front. Very life-saving. We didn't have it available. Unfortunately, like I said yesterday, they're becoming scarce in our part of the world. And so in that case, this is how the patient was treated by us. And we took the opportunity at that stage to also fix her back. This is she, I think, following her definitive surgery. APC3s also very high mortality rates because of the bleeding. This particular patient was treated during my training. So this patient presented with hemodynamic instability. The patient, you can see, already has an internal iliac artery injury on the left side. And so in that center, they have the expertise to do angioembolization as well as packing of the pelvis as the patient is coming in. And she was taken in for that immediately. And then that's what saved her life. And she went on to do very well following her final surgery. Vertical shears are also life-threatening injuries as well. This is how you can pick them up. This one is a more subtle one, but you can see there's a dislocation of the symphysis in the front. There's a dislocation of the SI joint at the back. And this one needs to be recognized very early because it has the added disadvantage of, limb shortening and it can change a patient's life if it's not picked up timeously and treated timeously as well. It can happen through the joints, or sometimes it can happen via fractures in the front, where now bladder injuries are very common. They call this sort of thing a saddle injury, where you have a left-sided and a right-sided pubic rami fractures in the front on the same patients. Then you need to actively go and look for intrapelvic injuries such as bladder injuries, which this patient had. This is a young lady who we treated earlier on in my career around, I think, 9 years ago. This lady was on her way to work, and then she was hit by a bus, and she was dragged across the road for about 10 meters, according to the people who witnessed it. And this is what I saw on my WhatsApp from a hospital which is about 25 to 30 kilometers away from Charlotte. And so when this doctor called me, it was about 3 o'clock in the morning, and I thought I was dreaming when I saw the phone. And I called him back, and he told me what he had. And so, we could talk the doctor through what needed to happen next. I wanted to get an opinion from you. You can see she also has a fracture of the femur on the same side. Obviously, this is going to be an open injury. And then I asked him, how did this patient make it to the CT scanner? Because this patient had no business going to the CT scanner at this stage. So what do we do now? What's your next step? Do you reduce it? Do you reduce the dislocation? Do you attempt to send her elsewhere if you're in a referral hospital? Or do you traction her and continue and do what you can where you are? Obviously, I think, a reduction is probably not going to happen. It's not going to help because the traction is severe and the patient doesn't have time for that. I think the most appropriate thing to do is probably to send the patient to a center that can treat them. And so luckily I knew the man very well, and I had to drive to his hospital so we can stabilize the patient before the patient was flown to a referral center in Johannesburg. This is she following our treatment of her. This injury has a mortality rate of more than 80%, and we were lucky, or the patient was lucky, to be treated timeously, and she survived. I think the last time I saw her was 2 years ago, which was a 5-year survival for her, and I haven't seen her since. So in summary, these are very severe injuries, but they are survivable. We do need protocols in place because protocols have been shown to improve results. And I do think around the world or in the cities that I've seen, certainly here in Greece, training definitely needs to be improved, and you need more surgeons who can treat these injuries. Thank you very much.
Thank you, Tammy. Any question? Yes, please. Professor Golalis.
Yeah, thank you very much. It was fantastic for us, the orthopedic surgeons. So I'd like to ask, what is the functionality after operations like that, and what is the infection rate?
Absolutely. So thank you for that, Dimitri. So, you know, if it's a very low grade sort of lateral compression, which is most people will see a lateral compression. Time is obviously of the essence, but if you pick it up early and if the surgical indications are there and the surgery is performed, infection rates tend to be very low if you follow the rules, you know, and it's often a simple plate and screw. The only thing with pelvic surgery is that the surgeries are long, it's deep surgery, and you are dissecting next to very scary lions and tigers. If you can get your way around them, get to the bone, do your reductions and plate them, the infections are low. For the severe cases that we've shown, which luckily are not as common, unfortunately, you know, they carry a high mortality. If the patient survives for the first 48 to 72 hours, they've been shown to survive, you know, in the long term, in 1 year or midterm or so. Unfortunately, their life changes. If you do a hemipelvectomy, for example, quality of life changes significantly. But your infection rates are higher if the injuries are open, if the injuries are contaminated, like any other injuries in orthopedics. If you're dealing with a closed injury, your infections are low. If your reductions are good, then your outcomes become exponentially better. That being said, in male patients, we have seen, Dr. Kai spoke about this yesterday, they come with occult other like long-term sequelae, like, you know, chronic pelvic pain. He did mention in male patients, we see a lot of erectile dysfunctions, which patients can sue you for, unfortunately. We see a lot of unhappiness long-term in some of the patients. But luckily, in the majority of them, the infections are kept low, and long-term sequelae are kept low, so then your results are better. But it can be detrimental if they're not picked up early, if you're operating them late, if they are missed and they come to you a year later, which happens a lot in Johannesburg. Yeah.
I am a Greek doctor working in a hospital, and I learned from ATLS that I can do a seat reduction in pelvic fracture, unstable pelvic fracture. I don't have a CT scanner. Is there any contraindication to do a reduction with a seat in a stable pelvic?
Sorry, is that a reduction for a dislocation of a joint or a reduction of a...
I'm not an orthopedic, I just know the pelvis is unstable. And this is the indication, according to ATLS, to put a sheet.
Oh, yes.
Is there any contraindication? I should think second time for something?
Thank you for that question. It's an important question. So the ATLS and the DSTC teach that if already from the field, if the paramedics or the first responder sees the patient and they suspect something is wrong with the pelvic ring, they teach to put a sheet, whether or not it's an APC, a vertical shear, and so on. And we agree with that teaching in the main part because it's going to save the patient's life during transportation. To answer a second question, where if you are not trained or you're not an orthopedic surgeon and you're a first responder, can you reduce a dislocation or a dislocation of a pelvic ring? Absolutely. You can do a lot of the diagnoses and a lot of the initial treatment based on the x-rays alone. You don't need to have a CT scan in order to see most of the pathologies.
I have a question, Tammy. Why we don't change the guideline to use the club and not the seat, even with the paramedics? The club is easy to put.
I'm trying to choose my words carefully. Look, I think the C-clamp, as easy as it is, it's not without trouble. And, you know, I've read some of the papers in the literature about doing it on the field. In the military papers, if you read papers from, you know, war-based papers, they were doing them on the field, like you're saying now, Dr. Koulivaris. But I think we are asking for trouble if we just put that on the protocols. I think in the field, the safer thing and the easier thing to do is probably to put on a sheet and then get the patient to some sort of casualty where we can see what's happening first. C-clamp I would reserve for, you know, even a resident, even a fellow in orthopedics or someone like that, or anyone, even a general surgeon who's been trained to at least do the clamp in a controlled environment, in a theater or something like that. Because if it happens in the field, we're going to have disasters.
Really?
Yeah.
Do you take it out before the CT scanning?
You can send the patient to the scanner with a C-clamp. It's not a problem. And a lot of it is anyway carbon fiber, and so it's radiolucent. As I showed you, it's like 3-piece.
Yes, but it changed the pattern of the fracture.
Oh, I hear what you're saying. It's not a big problem to send the patient to a CT scanner with a C-clamp on. The only thing we advise or we teach the registrars is to always write on the X-ray request form if a patient either has a pelvic binder on, a C-clamp, or the patient has a sheet. Because you're right, it does change or it can mask a lot of the pathologies. If we can, we do an initial X-ray, and once a patient is more stable, the clamp or the sheet is taken off, and the patient is sent back for a plain film without a sheet, just to see the true nature of the injuries.
And one more, do you use the iliac obdurate views for acetabulum fracture, or you go straight away for CT scanning?
We do that a lot, especially if they're coming to us from referral centers all over Johannesburg and Pretoria. We do advise them to do an AP, Jude views, iliac oblique views, and obturator oblique views. You can get a lot of information from them if you don't have a CT scanner, or like I am where I am at Charlotte. It can take us up to a week, sometimes 2 weeks, to get a patient to a scanner. Yeah.
Thank you.
Thank you.
One more question.
I have a question, but also want to say thank you to everybody who is here. It's really exciting for somebody who's not in your field to sit here and listen and see the participation. Yes. It's really, really great. And thank you, Dr. Mazibuko, for what you've just said now. I wanted to ask, especially from our Greek friends, what kind of programs do you think that we should have to relate between, you know, Greece and South Africa with the two departments of, you know, of health in order to support more what you are doing now? You know, what I enjoyed, why I'm asking this question is that it's on a Sunday. We are all here, those who are not running the half marathon. In the center of Athens, we are all here, and we are participating. And of course, I'm thinking it would be good to hear from practitioners themselves how you would like us to improve the relations in this area. So currently, at the moment, we've had our associates from South Africa coming here and participating in this way. What else would you like to see? How would that be structured? Thank you.
The University of Athens and the University of Witwatersrand about 2 years ago, they have signed an agreement of cooperation, mutual cooperation. And under this umbrella, we do this change of professionals. People from South Africa come here to teach us trauma. People from Greece go to South Africa to do hands-on trauma and learn some more. And this is the initial motivation to do that. After long years of cooperation, we decided to go on this step forward. So after this now, we can expand this cooperation in other fields of interest, which I'm not aware what these could be. My proposals are related to trauma because this is where I'm dedicated. Nevertheless, the University of Athens can evaluate this idea and discuss with members of various specialities and see what we can do more on that. Professor Akadopoulos, the Dean of Medical School, could say something more if he wishes.
Yes, this is very interesting. I think that today's session proves that there's a lot of room for exchange of expertise and educational exchange, and I'm sure we can find more ways. I want to bring it down to the undergraduate level as well for our medical students, who, by the way, we have to say that thanks to you and to Professor Koulouvaris, all our medical students are now ATLS trained. They all get their ATLS certification before their degree for free. And that was a big achievement. Other than that, there's modern ways of exchanging, medical experience, like virtual sessions between the two countries, online sessions, live cases being transmitted. I think we can work on all of that. There's a lot of room.
And there's an advantage. We have exactly the same time between here and South Africa. We can open a Zoom meeting, 7 o'clock here, 7 o'clock in South Africa.
One more comment that from your help, we have proposed to the Ministry of Health and to Stavros Giannis Foundation the first line for us, because you have high expertise for trauma, to have an education center for all over, the nurses, the medical students, the residents, and the junior surgeons. Yes,
I think our colleagues from South Africa have shown that instituting a trauma system and proper education brings great results. They have also shown that ultimately investing in that trauma system and care saves money. We have already talked about this. What is lacking in Greece is political will. Political will to actually invest the money, personnel, in order to institute a functioning trauma system. I would propose that we try to mobilize, use our colleagues from South Africa with their arguments to mobilize the necessary political will here in Greece in order to institute correctly functioning trauma systems and the education necessary for that. And because ultimately, not only do you have better results for the patients, but it actually saves money. So what we are lacking is the political will. And perhaps our South African colleagues can help to mobilize that political will, that we can use that to lobby the people who are making decisions in the Ministry of Health in order to accomplish something of great value.
Actually, we have our lobby, Dr. Gianno, is the medical school and the Stavros Giannis Foundation. This is very critical for us. We have both for this campaign. I don't know, but if you agree, how they open the doors.
The effort is multiple for many years, and I agree with Panagiotis, and the support of foundation is critical to move on. And I agree with Yanu about the political will, but This is only one part of the problem. The other part of the problem is us, which make decisions, make lifetime decisions based on how we can live better for ourselves. And we don't pay any attention to the relative or to the other human. This is probably the most humanitarian part of medicine. You treat a patient that is dying, he doesn't have the ability to do any agreement with you regarding finances or something as a payback. So either you help or he dies. That's the deal. So probably a good motivation would be the ministry or those that take decision give an extra bonus or a motivation for people that want to do this and they don't take enough paybacks to stay at the comfort that other doctors have. So we're all involved in that.
Thank you.
20 minutes break.
Okay. Thank you very much, Dr. Mazbuko.